I invite Pushparajan for flag salutation. Pushparajan is the North Zone convener, co-convener of emergency life support.
We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its sword shall be our sword. We pledge our allegiance to it and realizing our responsibilities as the accredited member of this national organization. We, sir, we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind.
I invite Mr. Venugopal PP, Vice Chairman of ELS, Emergency Life Support.
Hello, good evening. Today, respected chairman of this program, Dr. Shashi, today's chief guest, State President IMA, Dr. Samuel Koshi, Secretary Benevan, and then dignitaries, other all dignitaries on the online, offline. My job is to welcome all the participants to this gathering, to this function. But before that, one or two words I would like to say here. This is one of the prestigious, socially committed program of state IMA, and moving with a vision and a mission of training every individual, at least one individual in the home. And this Herculean task is taken by the passion of ELS chairman, Dr. Shashi. Shashi, one word about Shashi. Shashi is so passionate about the program, and we heard a few meetings last day, and our state president and state secretary is also so passionate and so supportive to carry forward this program. And one story recently happened in Calicut. One of our senior doctors who collapsed in the roadside last month, in the December. He was actually attending our Navati celebration, Calicut, and returning back to home. But very interestingly, one of the doctors nearby, came and resuscitated him effectively and efficiently. Now this doctor is in the home and he is without any neurological disease. This is the core competency of this program. Now, with this short introduction, I am getting into my job. I welcome our chairman of this program, today's program, Dr. Shashidharan. He is also the chairman of ELS Training. I also welcome our state president, Dr. Samuel Koshi, to this function. I welcome Dr. Joseph Benevan, he is the state secretary IMA, to this function. I also welcome other our guests, auspicious guests are like Dr. Zakaria PT, immediate president IMA KSB.
Plus unmute.
Dr. Venu, please unmute.
Dr. Venu, please unmute yourself. Dr. Venu, please.
Venu, you're mute. Venu, you're mute. Unmute.
Venu, please, Sadev sir, keep muted. Venu, please unmute. Ellen John, please mute.
Alan John, that has to be muted.
Venu, unmute. Venu, please unmute.
Okay. In between it is getting, sorry, do you heard whatever, when it is getting?
Yes, sir. Up to Zakaria sir, we are.
Okay, up to Zakaria sir, you get it. Okay. So, I am repeating, I welcome all the
You are again mute.
Yeah, mute again.
me. Someone
Again,
is muting me without my knowledge. Someone else is muting me without my knowledge. Whenever people are, I think, don't like to my sound and talk. I welcome the senior leaders, Dr. Zakaria Piti. He is the immediate past president. Dr. Joseph Mani, National.
You are again muted, Venu.
Something is happening very wrong. Someone is, it is automatically getting
look at the screen and speak. And
yeah. And also I welcome Paul Raphael and also Pushparaj and all the faculty members who are taking classes here. And also welcome, now there is a 343 members already joined. We are waiting few more members. I'm welcoming each and everyone who is participating today's training TOT session. And thank you so much. Thank you at JIMN.
Next is presidential address. Respected State President Samuel Koshi, State Secretary Joseph Beneven, Vice President Joseph Mani, Mathanam Pilla sir, Chakrao sir, Senior ISA President Venkatagiru, senior leaders and my friends. Warm good evening to all of you. We welcome you to the TOT program on emergency life support. At this moment, we should remember Umar sir. It is under his vision, emergency life support was started in 1970. May his soul rest in peace. I apologize for any shortcoming. We were planning to conduct this as an offline program with hands-on training, but because of the COVID restriction, we had to restrict over to an online program. We will definitely conduct an offline program later. We will also conduct a mega public awareness program once the situation becomes favorable. Every citizen a lifesaver. This is our plan, our motto. We thank and appreciate from the bottom of our dream. Many branches are now conducting training programs, but it is quite important to make it uniform and systematic. Today, we will be discussing what is to be taught for common people and healthcare workers outside the hospital and as first-aid care in hospital. This is only a foundation course, not a substitute for advanced certification course in resuscitation, trauma care, and emergency condition, which we will conduct at a later occasion in district level or zonal level. After this, all branches are requested to conduct similar programs, preferably with their own faculties for the branch members who are not able to attend this TOT program and also for the healthcare workers in their area. With a collective effort, we can spread the awareness of in the public, concentrating on police, automobile workers, headload workers, Kudumbashri workers, teachers, and so on. Teachers are important because their help is essential for mass awareness among school children. In public awareness classes, we must spend a few minutes to create an awareness against hospital attacks and also to create an awareness in diseased organ donation. We also suggest all branches to conduct online awareness classes to public, similar to the one conducted by IMA Arogyam Anandam, conducted by Trivandrum branch under the leadership of Prasandan. We must also try to increase the circulation of our magazine, Nammude Arogyam, in our public awareness classes also. We are happy so many people are attending this program, even at the peak period of pandemic. I appreciate the great work done by the faculties to prepare the class of today and the next Thursday. Special thanks to Chakrao sir. He is only speaker from outside the state. He is working all the 24 hours, all the 7 days in a week to spread the message of resuscitation all over the world. Let me conclude by expressing my gratitude, the great effort taken by IMA office, especially Gopalakrishnan, Kiran, Jidesh, and so on. Thank you all. Next, the inauguration. I invite our beloved dynamic Samuel Kosi, State President, for inaugurating the TONT program and for the inaugural address.
Thank you, Dr. Shashi. Chairman of ELS, Dr. Shashidharan, our IPP, Dr. Sagriyasa, National Vice President, Dr. Joseph Mani, our State Secretary, Dr. Joseph Benavan, our past National President, Dr. Malkandar, our Chairman for Resuscitation Standing Committee, Dr. Chakrao, Dr. Paulo Rafael,
Sir, you are muted.
Samuel, you're muted.
Okay, in between it is getting muted. I think central control is there, muting everybody. Let me congratulate the ELS team for the excellent work they are doing. And this program also is being organized in an excellent manner. We all know that the ELS training or ELS programs can save a lot of lives. It can restart a life, and they can save a lot of lives also. Hence, this program or this training should be undertaken by each and every member of IMA, not only for IMA members, it should be undertaken by the general public also. So this theatre training, they're having it in 2 days, today and 10th of this month. So this training, we had to give this program, we had to give training for maximum number of IMA members. And those who have taken part in this TOT program should train the other members of the branches. That is the aim of this TOT program, so that maximum number of doctors can be trained in ELS programs. Because it's a must, and it's a need of the hour for each and every member of IMA to know resuscitation programs and how to restart a life. And the next phase of the program, as is being already pointed out by the chairman, is to have training for the paramedics. Now, hospitals, we have to train the paramedics so that another set of medical people can be trained in this aspect. Then the third phase, we have to go to the general public. That is a target for this. And the general public training is mainly based on compression-only life support, course training for general public. And the target for this year is to train students. And the target we have to achieve is training, the course training for 25 lakhs of students throughout the state in 1 day. So that's a mega resuscitation program that we have to do. And I know that the team, and that Dr. Shashidharan is capable of doing it, because they're all very capable and dedicated people, Dr. Venu, Dr. Paul, like array of team leaders. I don't want to name each and every one of them because they can do it and they will do it. That is my belief. And as already been pointed out by Shashi, an award will be given to a common man doing best resuscitation work during the year. And that will be awarded by our IMA Nilambur branch, the name of our late past president, Dr. E.K. Umma. I take this opportunity also to congratulate Dr. Chakrao. He is the chairman of Indian Resuscitation Council Federation, IRCF, just founded in 2017. And it is the IRCF who has introduced the compression-only life support training for our country. And he's also the chairman of IMA Standing Committee for Resuscitation. And I know that he is a very dedicated man, and under his leadership and training, the Kerala this team also can work wonderfully well. And with these words and with these ambitious programs, I believe that ELS of Kerala State branch is going to be one of the best committees we are going to have. And through this, we will achieve a lot. And with this belief, let me declare that this program and the program of ELS for this year is being inaugurated. Thank you. Jai IMA, Jai Hind.
Thank you, Sambal Kosi. Actually, he is the backbone of this TOT program. Now I invite our dynamic secretary, Joseph Benavan, to address. Benavan?
Yeah, sir. Dr. Shashidharan, Chairman, Emergency Life Support Training Program, Dr. Samuel Koshi, President, Dr. P.T. Sakriya, Immediate Past President, Dr. Joseph Mani, National Vice President, Dr. Martanda Pillai, Chairman, National Action Committee, Dr. Chakra Rao, Chairman, IMA Resuscitation Standing Committee, and also Chairman of the Indian Resuscitation Council Federation. Other leaders and members of the ELS team, that is Dr. Venugopal, Dr. Paul, Dr. Pushparaj, Dr. Dominic, and all the members, because this is a great effort in organizing this TOT program of the Emergency Life Support. One thing I would like to say is, the Emergency Life Support team is driven by the passion and the commitment of its chairman, Dr. Sashidharan. And seeing Dr. Sashidharan's passion, it's very infectious. It touches on everyone. And that's how the state has also been motivated to take up the challenge of, like I said, state president has rightly mentioned, of training 25 lakh school students this year. That's one objective. And at the same time, the training does not end there. We plan to go to each and every branch, every district, every zone, and probably we'll have all that in the physical format once the COVID subsides. A lot of effort and a lot of planning. This is such a well-knit team with so much of passion and their commitment, because every time you talk to each of these members, Dr. Venugopal, Dr. Paul, Dr. Pushparaj, they are oozing with enthusiasm, and it's their objective as every citizen a lifesaver. So the objective is to make sure that every citizen, before we go into the citizens, we need to train our doctors, that every doctor in Kerala State IMA, right now we have 35,000 and probably will reach beyond 45,000 this year, so that every member of IMA Kerala State branch becomes a lifesaver in certain situations. And we are all very adept with the techniques. And I wish to express my appreciation to Dr. Chakra Rao, who is the chairman of the Indian Resuscitation Council Federation. And I'm told that the compression-only life support system has been evolved by him, and he's as passionate as our chairman. I think the whole idea of emergency life support is it's infectious. We have a highly motivated and highly committed chairman at the national level, and it trickles down to every state. And I hope, seeing my chairman, I'm sure I only can understand what kind of spirit Dr. Chakra Rao must be having. And for Kerala State IMA, it's our privilege to have you here, sir, with us today. And I'm sure Dr. Sashidharan, this is a very fast-paced meeting because Dr. Sashidharan has said that the inauguration should not go beyond 7:30. So I'm not taking much of a time, but the ELS is one of our, like was rightly said by Dr. Venugopal, our projects for social commitment, and we intend to reach every family in the state. That's our goal for this year, like 25 lakh students, and at the same time, 25 lakh citizens, 25 lakh families, and probably 30,000-40,000 doctors. That's the target that we have set here. And I'm sure this team is going to achieve all those targets and go beyond that. So my best wishes, and the state IMA is wholeheartedly supporting all the activities and initiatives of ELS. We pledge our support to you because the enthusiasm that's shown by the team is infectious, and we are also committed to it. Thank you.
Thank you, Benavan. Actually, he is one of the pillars of this TOT program. Now, I request Sakariya sir, immediate past president, to speak a few words. Sakariya sir. Now, I invite Joseph Mani sir, National Vice President, to speak a few words.
Good evening to all of you. Most respected President Dr. Samuel Koshi, Secretary Dr. Benavan, Dr. Sashidharan, and all the dignitaries and my dear friends. I think it is a wonderful moment for IMA Kerala State Branch, giving training to the trainer of trainers of emergency life support scheme. And I think there is more, around 500 members are participating. If one member gives 100% training for emergency life support. I think 5 lakh people will be trained in this country. And as Dr. Samuel Kochi said, we are planning to give a training to 25 lakhs of students of this state. It's a very good, wonderful program. I congratulate all of you for taking such effort, and all the best wishes from the national headquarters of Indian Medical Association. As all of you know, we have 3.5 lakh doctors as members of Indian Medical Association, and all the best to the program and for the trainers. Thank you. Jai Hind, Jai IM.
Thank you, sir. Now I invite Martanda Pillai sir, Chairman of National Academy. Martanda sir.
Okay, so thank you, our state president, Benavan, Joseph and Shashidaran and all others. This basic life support committee and the program is definitely very important because if you want to work in a foreign country, whether you are a doctor or a nurse, for that matter, any healthcare worker has to know basic life support. Certification is very important. Without a certification for basic life support training, you cannot get a job. So that it is so much important. But only in our country, the importance of basic life support is not that much stressed. And I'm sure that this committee definitely will be addressing this problem. Even those issues that happen at the casualty level in government or private hospitals is mainly because the concerned doctor is not aware of basic life support. And what is to be done on a terminally ill patient or a serious patient is brought to the hospital or the casualty. What are the steps to be taken up? SOPs are not known to them. So I'm sure that this committee has a great responsibility to perform. The target has to be that every practicing doctor in Kerala, particularly, are given this basic life support training program. One thing more that you can definitely do is that the American Cardiological Society program is what is internationally recognized for this purpose. So we can definitely have a tie-up with this society through local agencies which are doing it, or directly, so that whatever certificate we give will be valid, not only in India, even in foreign countries if they are seeking job. So this program can even be extended to nursing personnel also. And this will definitely, you can make a lot of money also out of it, but the money is not what is more important, but the training. And the training has to be properly given. Just for the sake of giving training, just like Tiruvadirakali that is happening in the political scenario, we should not sort of have, say, 200 people given training in half an hour. And that is not the type of training that is to be given. It has to be minimum 2 days program. And the person who wants to get training has to be really motivated that a proper training is important, rather than having so many people at the same time given training maybe for half an hour or whatever. And you may have to have mannequins, and hands-on training also has to be given. So if you put your effort properly and you are beginning to this program in the proper way, with the proper affiliation with the international agencies, accredited agencies, you will be doing a yeoman service.
ശബ്ദം പോയി.
You're muted. Sir.
അവൻ മുട്ടേ.
My only request is do it properly and with a code which has proper recognition, and whatever logistic support you need, definitely all of us will be ready to provide you. Wish you all the best. You are starting in right earnestness, and I'm sure you will succeed and you make a mark in this field. Thank you.
Thank you, sir. Thank you, Martanda Billa sir. Now I invite Chakrarao sir. He is the chairman of the IMA Resuscitation Committee and also the chairman of IRCF. He is trying to spread the message of resuscitation all over the world. Over to you, sir. Chakrarao sir.
Good evening, everybody. I am Dr. Chakrarao. Actually, I was the retired additional director of Health Services, Andhra Pradesh. I was the secretary and the president of the Indian Society of Anesthesiologists National. Later, when we have found out on a survey in 2016, it shows that less than 2% of the people in India know about CPR. So that's why out of the 4,280 persons per 1 lakh in a year in India getting sudden cardiac arrest, we are not able to save anybody because 70% of these cardiac arrests are occurring outside the hospital and there is nobody knows about CPR. I told you, even the CPR is not in the curriculum of an MBBS or any other thing. It is something taught to the nurses, but every doctor thinks that he knows CPR, but it is not in the curriculum and nobody knows CPR when we really try to know that. So Indian Society of Anesthesiologists has asked me to start the program with Indian guidelines. So why there is an Indian guideline? Because American Heart Association since 1966 is doing CPR, and it is limited to only 6 countries, and some agencies are also doing CPR for limited people in India with an exemplary price. But now we wanted to bring CPR to the public. Public means it should be easily accessible. Every medical college or district should have one center to train people with an equipment. So we started this, and in India there are a lot of hurdles and obstacles and bottlenecks for everything because we have many religions, many languages, many areas, lot of superstitions and so on. So for all these things, the most important thing is we do not have a proper emergency medical system. The ambulance will not arrive within 3 minutes or even within half an hour. So in these circumstances, we should have something different from the Western world. In Western world, everywhere there will be an AED and there are trained people. For example, in Seattle, almost all the people are trained and most success rate of CPR, about 46% is observed in Seattle. But in India, even the doctors do not know. Everybody thinks that it is only the compression of the chest. Yes, sure, it is compression of the chest. How to compress and how many times you have to compress is also important. Here, we have come up with our own thing with a very, very economical way. And of course, and we are recognized on almost today, actually, now I have come up from the meeting of the World Federation of the Societies of Anesthesiologists, and ILCAR meeting we are attending, and we are at the venture because there is a Canadian society. There are two societies in America. There is no society or nobody in South America. There is one society in South Africa. There is they have not given even permission to the Gulf, and there is one Asian society that is in Singapore that is also a member from Japan is also a member there, and there is a European society. Now the Indian Society of Anesthesiologists has formed the Indian Resuscitation Council, and they have advised me when you say that it is an Indian Resuscitation Council is a part of Indian Society of Anesthesiologists, people cannot join. So we have changed it as Indian Resuscitation Council Federation, registered away from the Indian Society of Anesthesiologists under the number 8 of the company laws in 2013. And now we have admitted they have asked us to admit only the societies. So we have admitted the pediatricians and the neonatologists in this. And in the meanwhile, Dr. Jailal and Dr. Bakshi has seen us propagating this. And we have also once conducted one course for the SARC countries in 2018 from Delhi. Then Dr. Jailal has seen us. And then he told me, why don't we do it for everybody? Yes, everybody should be trained. Every citizen should be a lifesaver. That is our motto. And it is not every citizen or every doctor or anybody. It is the prerogative of all the people in the family. If you want to be safe, all the members of your family should know what is CPR. And there should be an availability of AED in the nearby places. So now we are asking and writing or influencing the government to provide or make it necessary or compulsory for any high-rise building or the apartments to at least to possess one AED. And AED is the most essential thing to make the defibrillation corrected. And not only that, you have to train your family members, you have to train your relatives, you have to train your friends, and you have to train your neighbors. Then only you are safe. Even if you go to your club, you first train your club members, then only you are safe. Because we do not know who will get the cardiac arrest. Sudden cardiac arrest can occur anytime, anywhere, for any age group. And we know that our president, past president, Abdul Kalam ji, has succumbed to death while he was talking, giving a lecture in Northeast. So like that, I have seen many stories of many people succumb to death by sudden cardiac arrest, and people staring at them and not reacting because they don't know. They have stunned themselves and they could not do anything. And finally, they were all brought dead to the casualty. So this should not happen, because in a cardiac arrest, the main problem is the inability of the myocardium to pump adequate oxygenated blood to the brain. So here the brain suffers. It is not a heart attack. In heart attack, there is a lack of blood supply to the heart itself. Here, because of the problem in the heart, it is not completely contracting and it is not pumping the blood. So first of all, you have to save the brain, and then you can take the help of the others. So in this, we will be teaching everybody how to recognize a cardiac arrest, how to make the scene safety, how to call. See, many of even our doctors, they do not know how to speak on a phone. How to speak on a phone is also important. So these are all the things what we are going to teach in the BCLS. We have changed the nomenclature as BCLS, Basic cardiopulmonary life support because there may be some problem with the copyrights of the American Heart Association. So apart from that, everything is same. And another issue, what I wanted to tell you is, we are at every year, we are attending the ILCAR. ILCAR is the main regulatory body of the societies of the CPR societies of the different countries. Different countries means, I told you there are only 6 societies that are available now, and India is going to take the place in next October. And we are also, for your information, we are also starting one journal soon, and we are also doing our own hybrid courses. Hybrid courses because hands-on is most important for any training in CPR. We are not able to do the hands-on for the last 2 years effectively because of the problem of COVID, but we have to resort to the hands-on training. I think Venkatagiri, welcome Venkatagiri, you have come. I think I have also seen Suguvargi somewhere, I don't know. Well, whatever it is, thank you Venkatagiri for attending this meeting, though it is a Kerala meeting. So what I wanted to tell is, let us save lives. Even with your 2 hands, you can save the life. There is no need of any equipment or anything because first of all, you compress the chest effectively, see that the blood is flown to the brain and is saved. The brain is saved. Then you can ask for the help and then you can bring the AED. So I told you the importance of AED also. So we have to struggle. We have to improve one by one. When I came to last time Thrissur, many people, even some churches have promised and some mosques have promised that we will buy mannequins and make them available every Sunday training and everything. But I don't know what has happened. But something is going on in Kerala. I definitely tell because of you all people involved in this. And whether it is an IMA or ISA, it doesn't matter. We are all doctors. We have to carry this message of making every citizen a lifesaver. Actually, I take the word of our Prime Minister, the Azadi Ka Amrit Mahotsav. We are completing 75 years of our independence. So this is the time. Let us start now itself. Let us not wait because we are celebrating a World Restart Heart Day on October 16th. Let us not wait till that. Let us start from today that we will do. Of course, you told that 25 lakh people, children you have to train. I have told that it is 2 million children will be trained. So it is more than that. I'm very happy. This 20,000, and we have also some online app available from Lardell that I can request them to be made available for you people. You can, because everybody, it is very difficult to share with the mannequin, but at least you try to compress and learn on a pillow or something like that. And not only this, this is Atmanirbhar Bharat, that is self-reliant India. Of course, Hindi I do not know much, but because I have to speak something catchy. Atmanirbhar Bharat, the self-reliant India, because let us have our own things. Let us improve our techniques and all, and learn CPR, save lives, and make every citizen a lifesaver. So now I may be actually nominated as the chairman of the standing committee of the IMA, but I am available at any time. Anytime we will do that, and don't feel think that only American Heart Association and only Americans can do this and Indians can do this. We are 140 crore population. Let us improve our skills and technique, and we can do much better than anybody. And another thing, we have to assess our work. So let us conduct one survey again. I will send you an app where it is a survey cum awareness program. It was designed by one of the medical companies, actually. So let us do that. And whenever anybody wants anything, we are ready to share and help or do anything. So I request, with this, I will end this. I think I have given some enthusiasm at least to start this. Of course, you have been doing it for the last so many years, but let us do something good for our country, and let us make it very simple. Simple means don't go for the cut shots of the training. Let us cut short the cost of the training and do the things. I thank you very much for inviting me. Thanks a lot. Thank you. Thank you all. I don't know all the names. I know only Shashidharan, Paul Raphael, and other people. I can identify even some of the anesthetists here. Thank you very much. Thank you. Thank you for giving the opportunity.
Thank you, sir.
Now, Venkatagiri, National President of ISA, is there. I invite him to speak few words. Venkatagiri, are you here? Venkatagiri? So
you have to unmute. Giri, you have to unmute.
So we have our past National Honorary Secretary.
Thank you. Thank you, Shashi. Chairman Shashi, State President, Secretary, National Leaders, and friends, and Dr. Chakra. I'm happy to participate in this training program. As what I wanted to speak, Chakra has told in detail. So it was, as he said, when Secretary Chakra was given this task of doing that. Every meeting I was telling that what we want to do is, see, be Indian. We should have Indian guidelines, because see, AHA guidelines are foreign, their body weight, totally it is different from our people body weight, our configuration or other things. So we should have our own guidelines. So we started the guidelines, and now it has really grown, and we have reached almost to the stage of getting the membership of ILCOR. Soon we will be getting that. And if we teach another 10 people in our house or surroundings or friends, we can make enough people know well in resuscitation and in CPR. We have to learn something from Andhra. See, Dr. Chakra could influence all the universities in Andhra, all the medical colleges give this training, but we have no others could do that. How we could do that, we have to see. Other thing is, it is not very simple. We have to have the mannequin. We had one matching grant like this when I was secretary, ISA, all branches we gave. If you buy one we will get free from ISA, we paid. And the Ladder gave that at a very cheap rate. That IMA can do that. Each branch, if they buy two, give two from IMA, seeing their branches, so that people can practice. This is what we have to do. Not just simply theory, but this is the thing which you have to tell. Shashi, you can make influence others and make that. Branches can have definitely. I think Malappuram and all branches in Kerala have purchased during that period. And anesthesia, ISA branches, like that, every IMA branch should have. Then we can definitely teach a good CPR to every person. That is the most important. With this, I wish all the best to this program, and hope Shashi will succeed in training everyone. See, you have done it in Wayanad, and I remember very well to children, government could do that. You could do it in whole of Kerala in this go. All the best, Shashi.
Thank you, Giri. He was the secretary when IRC was formed. Then we have our past National Honorary Secretary Ashokan sir, past National Vice President Sidi sir, our Treasurer Sini Priyadashini, Senior Vice President Gopi Kumar sir, WDW Chairman Rajlakshmi Madam, all the state office bearers and past presidents and strong pillars of IMA with us. We recognize, appreciate, and value your presence and request for your blessing for our activities. Now, I invite Paulo Rafael, the convener of ELS, for vote of thanks. He was the secretary since the ELS was formed, and he is also a member of IMA Standing Committee on Resuscitation. Paul?
Thank you, sir. Respected State President, Dr. Samuel Koshi, State Secretary, Dr. Joseph Benuan, national leaders, Dr. Chakrarao, sir, Martanda Pilla, sir, Joseph Mani, sir, and all other senior leaders here, my chairman, dynamic chairman, Dr. Shashi, sir, and all my colleagues. I'm really surprised and really happy to see such a big number participant remaining 500 from the start, and that whole credit goes to the chairman and the whole of the ELS team. So I take this opportunity to thank all who are participating here for making this virtual function a memorable one. I'm extremely thankful to our State President, Dr. Samuel Koshi, for inaugurating this function, and also felicitating the occasion. I thank Dr. Joseph Benuan, sir, Dr. Martanda Pilla, sir, Dr. Chakrarao, sir, and Dr. Venkatagiri, sir. And if somebody's name is left, please pardon me, because it is a small screen what is seen here. I know that many leaders are there, and with such a big number, we can achieve the task. And as I'm very happy that Dr. Chakrarao, sir, has joined here. And he's the person who was behind this in bringing this resuscitation to the Indian team, because if you see at the census, if you see out of 1,04,800 people are dying in India. If you see the census in the US, it is just hardly 60 to 150 only. This is because it is not that it is there people are not knowing it, because these things are not reached to the common people. Those who go to abroad, they are the people who are seeking the training, and which was very expensive. And he's the one who has made it free for all the public, so that it goes to each and every person, and all citizens will be a lifesaver. That is our motto. The motto of the ELS is that. Motto of the IRCS if that. And training, we are reaching finally to the common man, where the maximum cardiac arrest is happening at home, where there are no doctors, there are no nurses, no paramedical staff. It has to be from the family member. So that is our aim. And thank you very much. And thank you all. And also sorry for taking a little bit more time. And I will straight away go to the training after the chairman says. Thank you very much. Shashi sir, you have to unmute.
Yes. Here is the end of the inauguration program. Now, thank you for all participating. Now we have to start the DOT program. I invite Dr. Paul to take over.
Okay, thank you very much. I've already spoken about the training, and the training will be for 2 days. Today we are concentrating mainly on the cardiopulmonary resuscitation, and we have a good number of speakers. And the next one will be with the trauma, first aid, etc. So it is a 2-day virtual program. We wanted it to be in a physical form, so that you will all be able to do much better. But definitely we'll have a chance to do that also. This last year also, there was a training in this manner on the physical way. Then we had to stop in March because of the lockdown. We wanted to train the lawyers also. It was on the last minute. These were all called off. So our dream will be possible to train all the people. School children is the best way of reaching the family, and they have the most energy and enthusiasm. And finally, every citizen will be able to do this. So let me start with the the first talk, as I told you, it is for the layman we are focusing on. And the first talk will be about the compression only life support. That has been introduced by the IRC for the first people, and Dr. Chakrarao sir was the brain behind it. So that will be spoken to you by none other than the chairman of ELS, Dr. Shashidharan sir. Over to you, Shashidharan sir.
Can you hear? Can I start?
Yes, you are audible.
Can you hear the slides?
Yeah, we can see the slides.
Yes. We are very thankful to the office bearers of IMA, especially the President Dr. Samuel Koshi and Secretary Joseph Benevent for entrusting us the activities of ELS for this year. Unexpected death can occur due to disease and trauma. Many of them may be prevented. Mortality and morbidity can be reduced if timely resuscitation and first aid were given. This must be started by person who witnessed the incident and should be continued at the medical facilities. Wrong action makes situation worse. That is why IMA started emergency care and life support training program. We must make every citizen a lifesaver. We must train them as per the skill and knowledge. ELS training include training in resuscitation, trauma care, and primary care in life-threatening situations. Slide one. Yes. For resuscitation, we are following IRC guidelines. This includes 3 modules: compression only life support for common people, basic cardiopulmonary life support for medics and paramedics outside the hospital, and comprehensive cardiopulmonary life support for medics and paramedics inside the hospital. Here is the detailed algorithm of the 3. COLS is colored yellow, BCLS is green, and CCLS blue. The CCLS is a 3-hour training program for public. BCLS is a 6 hours training program certification course, and CCLS is a more than 9 hours certification program. Thus, we will conduct at state level and zonal level later. All these medical organizations has accepted IRC guidelines. Now, we can start compression only life support. As compression only life support is for common people, I am proceeding in Malayalam. I hope all of you can understand Malayalam. തുടങ്ങുന്നതിന് മുമ്പായിട്ട് 2 സംഭവങ്ങൾ, ഒരു 3 മാസത്തിനിടയ്ക്ക് കോഴിക്കോട് തന്നെ നടന്ന 2 സംഭവങ്ങളാണ് നിങ്ങളുടെ ഓർമ്മയിൽപ്പെടുത്തുന്നത്. ഒന്ന്, 2 ഡോക്ടർമാരായിരുന്നു. ഒന്ന്, ഒരു ഡോക്ടർ കാർ ഇറങ്ങി വരുമ്പോ ഒരു വണ്ടി വന്ന് മുട്ടി, അൺബോധാവസ്ഥയിൽ വീണു. അദ്ദേഹത്തെ അതിന്റെ ചുറ്റും ആൾക്കാരൊക്കെ കൂടി കുറച്ച്, അപ്പോൾ അതിലെ വന്ന ഒരു ഡോക്ടറാന്ന് അറിഞ്ഞിട്ടൊന്നുമല്ല, ഇദ്ദേഹത്തെ അടുത്തുള്ള ഹോസ്പിറ്റലിലേക്ക് റിസസിറ്റേഷൻ കൊണ്ടുപോയി. അദ്ദേഹം ഇന്ന് മിക്കവാറും പൂർണ്ണ ആരോഗ്യവാനായി തന്നെ ഇരിക്കുന്നുണ്ട്. മറ്റൊരു സംഭവം, അത് കഴിഞ്ഞ് 2 ദിവസത്തിന് ശേഷം സംഭവിച്ചതാണ്. ഒരു ഷട്ടിൽ കോർട്ടിൽ കളിച്ചുകൊണ്ടിരിക്കുകയായിരുന്നു. പെട്ടെന്ന് അദ്ദേഹം കുഴഞ്ഞു വീണു. കൂടെ ആൾക്കാരുണ്ടായിരുന്നു. അവർക്ക് എന്താ ചെയ്യേണ്ടതെന്ന് അറിഞ്ഞില്ല. അവര് അവിടെ ഹോസ്പിറ്റലിലേക്ക് എത്തിയപ്പോഴേക്കും അദ്ദേഹം മരിച്ചു പോയിരുന്നു.
Sorry for the interruption. You have the slides moving, or are you showing slides?
You are not seeing.
Okay. We are seeing only your first slide.
Yes, that's it. Now.
Okay. Sorry, sir. Continue.
Can you see? Yes, sir. Then ഇങ്ങനെ ഒരാൾ കുഴഞ്ഞു വീഴുമ്പോ നമ്മൾ എന്താ ചെയ്യേണ്ടത്? സാധാരണക്കാരനായ ഒരാൾ എന്ത് ചെയ്യണം? കുഴഞ്ഞു വീഴൽ എവിടെ വേണമെങ്കിലും ആവാം. വണ്ടി ഓടിക്കുമ്പോഴാവാം, പഠിക്കുമ്പോഴാവാം, ഒരു ജോലി ചെയ്യുമ്പോഴാവാം, ഭക്ഷണം പാകം ചെയ്യുമ്പോഴാവാം, പേപ്പർ വായിക്കുമ്പോഴാവാം. ഇത്തരം സന്ദർഭത്തിൽ എന്ത് ചെയ്യണം? അതിനെക്കുറിച്ചാണ് പഠിപ്പിക്കുന്നത്. ആക്ച്വലി ഈ ക്ലാസ് നിങ്ങൾക്ക് വേണ്ടിയല്ല, നിങ്ങൾ മറ്റുള്ളവരെ പഠിപ്പിക്കാൻ വേണ്ടിയാണ്. അതുകൊണ്ട് ഞാൻ അവരുടെ സ്റ്റാൻഡേർഡിലാണ് സംസാരിച്ചുകൊണ്ടിരിക്കുന്നത്. ക്ഷമിക്കണം. എന്തുകൊണ്ടാണ് സ്ലൈഡ് കാണുന്നില്ലേ? എന്തുകൊണ്ടാണ് ഒരാൾ കുഴഞ്ഞു വീഴുന്നത്? പല കാരണങ്ങളെ കൊണ്ടാവാം. ഇത് ഞാൻ കൂടുതൽ വിശദമായിട്ട് പറയുന്നില്ല, ഡോക്ടേഴ്സ് കമ്മ്യൂണിറ്റി ആയതുകൊണ്ട് പറയുന്നില്ല. ഇറ്റ് മേ ബി ഡ്യൂ ടു കാർഡിയാക് അറസ്റ്റ്, ഹെഡ് ഇഞ്ചുറി ആവാം, സ്ട്രോക്ക് ആവാം, ഡയബറ്റീസിൽ ഹൈപ്പോഗ്ലൈസീമിയ ആവാം, ഹൈപ്പർഗ്ലൈസീമിയ ആവാം, ആൽക്കഹോളിക് ഉണ്ടാവാം, ചോക്കിംഗ് ആവാം, ആക്സിഡന്റ്സോ സൂയിസൈഡോ ഒക്കെ ആവാം. റിഗാർഡിംഗ് കാർഡിയാക് അറസ്റ്റ്, it may be cardiac arrest. It is the most common cause of cardiac arrest in adults. കാർഡിയക് അറസ്റ്റ് എന്ന് പറഞ്ഞാൽ കണ്ടക്റ്റീവ് സിസ്റ്റത്തിന്റെ പ്രോബ്ലം കൊണ്ട് വരുന്നതാണ്. അത് ഹൃദയത്തിൽ ബ്ലഡ് ഉണ്ട്, ബ്ലഡിൽ ഓക്സിജൻ ഉണ്ട്, പക്ഷെ എന്താണ് പമ്പിങ് ആക്ഷൻ മാത്രമേ ഉള്ളൂ. അതിൽ ഉടൻ തന്നെ റെസിസിറ്റേഷൻ ആരംഭിക്കണം, അല്ലെങ്കിൽ ആൾ മരിച്ചു പോകും. നേരം മയോകാർഡിയൽ ഇൻഫാക്ഷൻ അതാണെങ്കിൽ കൊറോണറി ആർട്ടറീസിന് ബ്ലോക്ക് വരുന്നതാണ്. അതിൽ കുറച്ച് സമയം കിട്ടും, പെയിൻ ഉണ്ടാവാം, വാർണിംഗ് സൈൻസ് ഉണ്ടാവാം, കുറച്ചുകൂടി സമയം കിട്ടിയെന്ന് വരും. ഈ കാര്യങ്ങൾ നിങ്ങൾ സമയമെടുത്ത് തന്നെ പബ്ലിക്കിനെ പഠിപ്പിച്ചു കൊടുക്കണം. ഇനി ഡോക്ടർ കമ്മ്യൂണിറ്റി ആയതുകൊണ്ട് അധിക സമയം അതിനെക്കുറിച്ച് പറയുന്നില്ല. നമ്മുടെ രണ്ട് പ്രധാനപ്പെട്ട അവയവങ്ങളാണ് ബ്രെയിനും ഹാർട്ടും. 3 മിനിറ്റ് ഹൃദയം നിറഞ്ഞിട്ടുണ്ടെങ്കിൽ 24 മണിക്കൂറും ഇടതടവില്ലാതെ പ്രവർത്തിച്ചുകൊണ്ടിരിക്കുന്ന ഒരു ഓർഗനാണ്. അതിൽ 3 മിനിറ്റ് നിന്ന് പോയാൽ, പമ്പിങ് ആക്ഷൻ നിന്ന് പോയാൽ ശരീരത്തിലെ വിവിധ ഭാഗങ്ങളിലേക്ക് ബ്ലഡ് സപ്ലൈ ഉണ്ടാവില്ല. 10 മിനിറ്റ് അബോധാവസ്ഥയിൽ പോകും. 10 മിനിറ്റ് നിന്നാലോ ഇറിവേഴ്സിബിൾ ഡാമേജ് ദാറ്റ് ക്യാൻ ഹാപ്പൻ. അത് പ്രിവെന്റ് ചെയ്യുക എന്നുള്ളതാണ് എല്ലാ ലൈഫ് സപ്പോർട്ടിന്റെയും അത് ജീവരക്ഷാ പ്രവർത്തനത്തിന്റെയും ധർമ്മം എന്ന് പറഞ്ഞാൽ. കമ്മിങ് ടു കംപ്രഷൻ ഓൺലി ലൈഫ് സപ്പോർട്ട്, മുമ്പ് പറഞ്ഞ പോലെ നെഞ്ചമർത്തൽ മാത്രമായ ജീവരക്ഷാ പ്രവർത്തനം അത് സാധാരണ ജനങ്ങൾക്കുള്ളതാണ്. ഇത് എപ്പോഴാണ് ചെയ്യേണ്ടത്? ഇത് സ്ലൈഡിൽ ഇംഗ്ലീഷിലും മലയാളത്തിലും ഉണ്ടാവും, ഏത് വേണമെങ്കിലും നിങ്ങൾക്ക് ഫോളോ ചെയ്യാം. ഒരാൾ നിങ്ങളുടെ മുമ്പിൽ കുഴഞ്ഞു വീഴുന്നത് കണ്ടാൽ, അല്ലെങ്കിൽ കുഴഞ്ഞു വീണിട്ട് അധിക സമയമായിട്ടില്ല എന്ന് കണ്ടാൽ ചെയ്യേണ്ട പ്രവർത്തനം ജീവരക്ഷാ പ്രവർത്തനമാണിത്. എല്ലാ ജീവരക്ഷാ പ്രവർത്തനവും ശരിയായ രീതിയിലാവണമെങ്കിൽ ചില തുടർ പ്രവർത്തനങ്ങൾ നടന്നുകൊണ്ടിരിക്കണം. കംപ്രഷൻ ഓൺലി ലൈഫ് സപ്പോർട്ടിൽ 3 ചങ്ങലക്കണ്ണികളാണുള്ളത്. ഒന്നാമത്തെ കമ്പലക്കണ്ണി എന്ന് പറഞ്ഞാൽ കാരണം കണ്ടെത്തുക, കൂടുതൽ പോരെ വിളിച്ചു വരുത്തുക. പിന്നെ കഴിയുന്നതും വേഗം നെഞ്ചമർത്തൽ ആരംഭിക്കുക. 3ാമത്തെ കണ്ണി എന്ന് പറഞ്ഞാൽ ഉചിതമായ സ്ഥലത്തേക്ക് ആൾക്കാരെ എത്തിക്കുക എന്നുള്ളത്. പെട്ടെന്ന് ഒരാൾ വീണ് നമ്മൾ എന്താ ചെയ്യുക? ഇത് പ്രത്യേകിച്ച് ആൾക്കാർക്ക് പറഞ്ഞു കൊടുക്കണം. ഈ ക്രൗഡിൽ ഈ ഓഡിയൻസിൽ ഞാൻ അധികം സ്ട്രെസ് കൊടുത്ത് പറയുന്നില്ല. ആദ്യമായിട്ട് ചെയ്യേണ്ടത് സ്ഥലം സുരക്ഷിതമാണോ നോക്കുകയാണ്. ഒരാൾ കുഴഞ്ഞു വീണ് കണ്ടാൽ ഉടനെ അയാളെ ചെന്ന് തൊടാൻ പാടില്ല. തൊട്ടാൽ ചിലപ്പോൾ ഒരു ഇലക്ട്രിക് ഷോക്ക് കൊണ്ടാവും സംഭവിച്ചത്. അയാളെ തൊട്ടാൽ എന്താ സംഭവിക്കുക? അവർക്ക് നമുക്കും ഷോക്ക് കിട്ടും. അതുകൊണ്ട് ഈ സ്ഥലം സുരക്ഷിതമാണോ എന്ന് നോക്കുകയാണ്. എൻഷുവർ സീൻ സേഫ്റ്റി, അതാണ് എല്ലാ ജീവരക്ഷാ പ്രവർത്തനങ്ങളുടെയും ഫസ്റ്റ് സ്റ്റെപ്പ്. ഈ സംഭവങ്ങളിലൊക്കെ ആണെങ്കിൽ ഇവിടെ ഇലക്ട്രിക് ഷോക്ക് കെട്ടി കിടക്കുകയാണ്, അയാളെ ചെന്ന് തൊട്ടാൻ താണ്ടാവുക പറയേണ്ട ആവശ്യമില്ല. അതുപോലെ കത്തിക്കൊണ്ടിരിക്കുന്ന വീട്ടില് ചാടി കയറിയാൽ ചെന്ന് പോയാൽ എന്താണ്ടാവുക? നമ്മൾ കൂടി അതിൽ പെട്ടുപോയി എന്ന് വരാം. അതേപോലെ തന്നെ നടു റോഡിലെ ഹൈവേയിലെ ഒരു നാൾ വീണെടുക്കേണ്ടത് നമ്മൾ റോഡിൽ ചെന്നാൽ എന്താണ്ടാവുക? ചിലപ്പോൾ വേറൊരു വണ്ടി വന്ന് നമ്മളെ മുട്ടി വയ്ക്കും. അപ്പൊ എന്ത് ചെയ്യണം? എന്തെങ്കിലും അപകടമുണ്ടോ എന്ന് നോക്കണം. അതിനുശേഷം മാത്രമേ ജീവരക്ഷാ പ്രവർത്തനത്തിന് ഏർപ്പെടാൻ പാടുള്ളൂ. അതായത് എന്തെങ്കിലും അപകടം ഉണ്ടോ എന്ന് നോക്കുക, രോഗിയെ സുരക്ഷിതമായ സ്ഥലത്തേക്ക് മാറ്റിയ ശേഷം വേണം നമ്മൾ ജീവരക്ഷാ പ്രവർത്തനം ആരംഭിക്കാൻ. അപ്പൊ ഫസ്റ്റ് സ്റ്റെപ്പ് എൻഷുവർ സീൻ സേഫ്റ്റി. പിന്നെ എന്താ ചെയ്യേണ്ടത്? ചെക്ക് റെസ്പോൺസ്. ചെക്ക് റെസ്പോൺസ് എന്താ ചെയ്യേണ്ടത്? പ്രതികരിക്കുന്നുണ്ടോ എന്ന് നോക്കുക. അതിനെന്താ ചെയ്യേണ്ടത്? മുന്നിൽ നിന്നുകൊണ്ട് 2 ചുമലിലും തട്ടി ഉറക്കെ ചോദിച്ചു നോക്കണം എന്തു പറ്റിയെന്ന്. എന്തു പറ്റിയെന്നോ പേര് വിളിക്കുക, എന്തെങ്കിലും ചെയ്യണം. ഇതിൽ ഓരോ വാക്കും പ്രധാനപ്പെട്ടതാണ്. അത് സമയമെടുത്ത് തന്നെ പബ്ലിക്കിന് പറഞ്ഞു കൊടുക്കണം. എന്തിനു അതിലിട്ട് കുലുക്കാൻ പാടില്ല. കുലുക്കിയത് സംഭവിക്കുക വീണതാണ്. ചിലപ്പോ സ്പൈനൊക്കെ ഫ്രാക്ചർ എന്തെങ്കിലും വന്നിട്ടുണ്ടാവാം. അത് കുലുക്കിയിട്ടെങ്കിൽ കൂടുതലാവാം. സുഷുമ്നയ്ക്ക് കേട് വന്ന പാരാപ്ലീജിയ, 2 കാലും തളരുന്ന അവസ്ഥ ഉണ്ടാവാം. അതേപോലെ തലട്ട് കുണുക്കരുത്. തലട്ട് കുണിക്കുക എന്താ സംഭവിക്കുക? ഇതേപോലെ തന്നെ കഴുത്തിലെ കശേരിക്കൊക്കെ കേട് വന്നാൽ പാരാപ്ലീജിയ ഒക്കെ ഉണ്ടായി വരാം. പിന്നെ 2 ചുമലും തട്ടുന്ന പറയുന്ന കാരണം എന്താ? ചിലപ്പോൾ ഹെമിപ്ലീജിയ ആണെങ്കിൽ ഒരു സൈഡിൽ സെൻസേഷൻ ഉണ്ടായിട്ടാണ്. അപ്പം മുന്നിൽ നിന്നുകൊണ്ട് 2 ചുമലിലും തട്ടി ഉറക്കെ ചോദിച്ചു നോക്കുക എന്തെങ്കിലും കുഴപ്പമുണ്ടോ എന്നുള്ളത്. അതിന് നമ്മൾ എന്താ നോക്കണത്? ആംഗ്യം കൊണ്ടോ ശബ്ദം കൊണ്ടോ അയാൾ ഏതെങ്കിലും രീതിയിൽ പ്രതികരിക്കുന്നുണ്ടോ നോക്കുക. ആ ശബ്ദം ഉണ്ടാക്കിയിട്ടാണെങ്കിൽ ആംഗ്യം ശരിയായ അർത്ഥവത്തായ രീതിയിൽ ആംഗ്യം കാണിച്ചോ പ്രതികരിക്കുന്നുണ്ടോ നോക്കുക. അതോടൊപ്പം തന്നെ എന്ത് നോക്കണം? ശ്വാസോച്ഛ്വാസം ഉണ്ടോ എന്ന് നോക്കണം. ശ്വാസോച്ഛ്വാസം ഉണ്ടോ എന്ന് നോക്കാൻ സാധാരണക്കാർക്കും പറ്റും. പക്ഷെ നമ്മൾ പബ്ലിക്കിനെ പഠിക്കുമ്പോൾ ആദ്യം പഠിപ്പിക്കുമ്പോൾ ഒന്നും പൾസ് നോക്കാനൊന്നും പഠിപ്പിക്കുന്നില്ല. ഈ സമയത്ത് തന്നെ ശ്വാസോച്ഛ്വാസം ഉണ്ടോ എന്ന് നോക്കാനാണ് പറയുന്നത്. അപ്പോൾ അങ്ങനെ ചെയ്യുമ്പോൾ എന്താണ്? ശ്വാസോച്ഛ്വാസം ആർക്കും നോക്കാൻ പറ്റും. അപ്പോൾ റെസ്പോണ്ടിങ് വെർബലി, ആംഗ്യം കൊണ്ടോ ശബ്ദം ഉണ്ടാക്കും പ്രതികരിക്കുന്നുണ്ടോ നോക്കുക. അതോടൊപ്പം തന്നെ ശ്വാസോച്ഛ്വാസം ഉണ്ടോ എന്ന് നോക്കുക. പിന്നെ പ്രതികരിക്കുന്നുണ്ട്, ശ്വാസോച്ഛ്വാസം ഉണ്ടെങ്കിൽ നമുക്ക് കുറച്ച് ആശ്വസിക്കാം. ശരിയായ വൈദ്യപരിചരണം എത്തുന്നതുവരെ രോഗിയെ നിരീക്ഷിച്ചുകൊണ്ടിരിക്കാം. പക്ഷെ അവിടെ അത് നിർത്തരുത്. വൈദ്യസഹായം എത്തിക്കാൻ നോക്കണം. ചിലപ്പോൾ അത് മയോകാർഡിയൽ ഇൻഫാക്ഷൻ തുടക്കമായിരിക്കാം, സ്ട്രോക്കിന്റെ തുടക്കമായിരിക്കാം, ഡയബറ്റീസ് ഹൈപ്പോഗ്ലൈസീമിയ ആവാം. ഇതിലൊക്കെ നമ്മൾ ജീവരക്ഷാ അയാൾക്ക് വൈദ്യസഹായം എത്തിക്കാൻ നോക്കണം. അതല്ലെങ്കിൽ കൂടെ അപകടം വരും. അതിൽ കുറച്ച് സമയം കിട്ടിയെന്ന് വരാം. പക്ഷെ നേരെ മറിച്ച് നോൺ റെസ്പോൺസീവ് ആണെങ്കിൽ, യാതൊരു പ്രതികരണം ഇല്ലെങ്കിൽ ഉടൻ തന്നെ നമ്മുടെ ജീവരക്ഷാ പ്രവർത്തനം തുടരണം. യാതൊരു പ്രതികരണം ഇല്ലെങ്കിൽ ആദ്യമായിട്ട് നമ്മൾ എന്താ ചെയ്യേണ്ടത്? കൂടുതൽ ആൾക്കാരെ വിളിച്ചു വരുത്താൻ നോക്കണം. എങ്ങനെ ചെയ്യാം? അടുത്തൊരാളുണ്ടെങ്കിൽ അവരോട് ആരെങ്കിലും വിളിക്കാനോ ഒരു ആംബുലൻസ് കൊണ്ടുവരാനോ ആംബുലൻസ് എന്ന് പറഞ്ഞാൽ ചിലപ്പോൾ കിട്ടിയില്ലാന്ന് വരും, ഒരു വണ്ടി കൊണ്ടുവരാൻ പറയാം. പിന്നെ അതില്ല, നമ്മുടെ അടുത്തൊരു ഫോൺ ഉണ്ടെങ്കിൽ ആ ഫോൺ നമ്പറിൽ പോയി വിളിച്ചിട്ട് നമുക്ക് ജീവരക്ഷാ പ്രവർത്തനം ആരംഭിക്കാം. ഇപ്പൊ നമ്മുടെ എല്ലാവരുടെ കയ്യിലും മൊബൈൽ ഫോൺ ഉണ്ട്. അത് സ്പീക്കറിൽ ഇട്ടുകൊണ്ട് നമ്മൾ സമയം കളയാതെ തന്നെ ജീവരക്ഷാ പ്രവർത്തനം ആരംഭിച്ചുകൊണ്ട് തന്നെ നമുക്ക് ആൾക്കാരെ വിളിച്ചു വരുത്താം. ഇങ്ങനെ വിളിക്കുമ്പോൾ, മൊബൈൽ ഫോണിൽ വിളിക്കുമ്പോൾ നമ്മളെ പറ്റിയിട്ട്, രോഗിയെ പറ്റിയിട്ട്, അതുപോലെ സ്ഥലത്തെ പറ്റിയിട്ട്, രോഗിയുടെ ഏകദേശ അവസ്ഥ, ഇതൊക്കെ ഒന്ന് പറഞ്ഞു കൊടുക്കണം. പിന്നെ ഫോൺ ഒരിക്കലും ഓഫാക്കി വെക്കരുത്. ഇപ്പോൾ ടെലിഫോണിക് CPR എന്നൊരു പരിപാടി ഉണ്ട്. ഇതോടൊപ്പം തന്നെ ഈ എമർജൻസി നമ്പറുകൾ ഒന്ന് പബ്ലിക്കിന് പറഞ്ഞു കൊടുക്കണം. 100, 101 പോലീസ്, ഫയർ സ്റ്റേഷൻ, അതുപോലെ 101 ആംബുലൻസ്, അതുപോലെ തന്നെ അതിലൊക്കെ 112 ഇപ്പോഴത്തെ എല്ലാ എമർജൻസി നമ്പർ ക്രോഡീകരിച്ച നമ്പറാണ്. അതോടൊപ്പം തന്നെ അടുത്തുള്ള ഹോസ്പിറ്റലിലെ എമർജൻസി നമ്പർ ഡിപ്പാർട്ട്മെന്റ് നമ്പർ കൂടി ഫോണിൽ സേവ് ചെയ്ത് വെക്കാൻ പറയണം. ഇപ്പം ടെലിഫോണിക് CPR എന്നൊരു സംവിധാനം ഉണ്ട്. അതിലാണെങ്കിൽ അവിടെ നിന്ന് നമുക്ക് നിർദ്ദേശങ്ങൾ നൽകും. അങ്ങനെ അമർത്തൂ, നെഞ്ചിന്റെ ഭാഗത്ത് അമർത്തൂ, എത്ര അമർത്തൂ എന്നൊക്കെ പറഞ്ഞിട്ട്. അതേപോലെ തന്നെ ചക്രാവ് സാർ പറഞ്ഞ പോലെ QCPR ഉണ്ട്. അതാണെങ്കിൽ ക്യാമറ ഓൺ ചെയ്ത് വെച്ചാൽ നമ്മുടെ ഷോൾഡർ മൂവ്മെന്റ് കണ്ടുകൊണ്ട് അവർക്ക് നിർദ്ദേശം പറ്റും. ഈ കാര്യങ്ങൾ ഓർത്തുകൊണ്ട് വേണം നമ്മൾ ചെയ്യാൻ. അപ്പൊ നമ്മുടെ ആദ്യം ചെയ്യേണ്ടത് സീൻ സേഫ്റ്റി, അത് കഴിഞ്ഞാൽ ചെക്ക് റെസ്പോൺസ്, അത് കഴിഞ്ഞാൽ നമ്മൾ ചെയ്യേണ്ടത് കൂടെ ആൾക്കാരെ വിളിച്ചു വരുത്താം. അതും കഴിഞ്ഞ ശേഷം നമുക്ക് ചെസ്റ്റ് കംപ്രഷൻ ആരംഭിക്കാം. ചെസ്റ്റ് കംപ്രഷൻ വളരെ ഇമ്പോർട്ടന്റ് ആണ്. അത് സമയമെടുത്ത് തന്നെ പൊതുജനങ്ങളെ പഠിപ്പിച്ചു കൊടുക്കണം. ഞാൻ ഇത് നമ്മൾ സാധാരണ 1.5 മണിക്കൂർ കൊണ്ട് പഠിപ്പിക്കുന്നതാണ്. ഇപ്പൊ 20 മിനിറ്റ് കൊണ്ട് ആക്കാൻ വേണ്ടി കുറച്ച് സ്പീഡിൽ പോവുകയാണ്. അപ്പൊ നെഞ്ചമർത്തലിന്റെ പ്രാധാന്യം എന്താണ്? നമ്മുടെ ഹൃദയം നെഞ്ചിന്റെ ഇടതു ഭാഗത്താണ് സ്ഥിതി ചെയ്യുന്നത്. 72 പ്രാവശ്യമാണ് മിനിറ്റിൽ സ്വയം പമ്പ് ചെയ്തുകൊണ്ടിരിക്കുന്നത്. പക്ഷെ നമ്മള് കംപ്രഷൻ കൊടുക്കുന്ന ഈ അഡൽട്ടില് പ്രായപൂർത്തിയായ ഒരാളിലെ ഏറ്റവും പ്രധാനപ്പെട്ട കാരണം കാർഡിയാക് അറസ്റ്റിന്റെ ഈ കണ്ടക്റ്റിംഗ് സിസ്റ്റത്തിന്റെ തകരാറാണ്. ഈ തകരാറ് സംഭവിക്കുമ്പോൾ ഹാർട്ടിൽ രക്തമുണ്ട്, ആ രക്തത്തെ ഓക്സിജനേഷൻ ഉണ്ട്, പമ്പിങ് ആക്ഷൻ മാത്രമേ കുറവുള്ളൂ. അപ്പൊ നമ്മൾ എന്താ ചെയ്യേണ്ടത്? കൃത്രിമമായി പമ്പ് ചെയ്യാൻ വേണ്ടി ശ്രമം നടത്തുന്നത്. അത് പണ്ടൊക്കെ നെഞ്ച് തുറന്നിട്ട് പമ്പ് ചെയ്യാതിരുന്നു ചെയ്യുന്നത്. ഇപ്പൊ അതൊന്നും വേണ്ട, നെഞ്ചിന്റെ പുറത്തുകൂടി ചെയ്താൽ തന്നെ എഫക്റ്റീവ് ആവും എന്നുള്ളതാണ് കണ്ടെത്തിയിട്ടുള്ളത്. അപ്പൊ 30 കംപ്രഷൻ കൊടുക്കുക. അത് കഴിഞ്ഞാൽ സാധാരണക്കാരൻ നിർത്തരുത്. പിന്നെയും 30 കംപ്രഷൻ, പിന്നെയും 30 കംപ്രഷൻ, പിന്നെയും 30 കംപ്രഷൻ, പിന്നെയും 30 കംപ്രഷൻ, അങ്ങനെ 5 പ്രാവശ്യം തുടർച്ചയായി ചെയ്യുക. അതിന്റെ ചെസ്റ്റ് കംപ്രഷൻ എഫക്റ്റീവ് ആവണമെങ്കിൽ ചെയ്യേണ്ട ചില കാര്യങ്ങൾ നമ്മൾ നോക്കേണ്ടതുണ്ട്. അതായത് ചെസ്റ്റ് കംപ്രഷൻ എഫക്റ്റീവ് ആവണമെങ്കിൽ കഴിയുന്നതും രോഗിയെ ഒരു ഹാർഡ് സർഫസിൽ ആക്കാൻ സൂക്ഷിക്കണം. കാരണം അങ്ങനെയാണ്, അല്ലെങ്കിൽ നമ്മൾ സോഫ്റ്റ് സർഫസിൽ മെത്തയിലോ അല്ലെങ്കിൽ വെള്ളത്തിലോ ഒക്കെ ആണെങ്കിൽ നമ്മൾ കൊടുക്കുന്ന കംപ്രഷൻ കുറച്ച് പുറത്തേക്ക് പോയി വരും. അതുകൊണ്ട് ഹാർഡ് സർഫസിലാക്കുകയാണ് ഏറ്റവും ഉത്തമം. പിന്നെ അതേപോലെ തന്നെ റെസ്ക്യൂറിന്റെ പൊസിഷൻ, നമ്മൾ കൊടുക്കുന്ന പൊസിഷൻ നമ്മൾ എങ്ങനെയാണ് നിൽക്കേണ്ടത്? രോഗിയുടെ ഒരു സൈഡിൽ നിന്ന് മുട്ടുകുത്തി നിൽക്കുക. നിലത്ത് കിടക്കുന്ന രോഗിയാണെങ്കിൽ മുട്ടുകുത്തി നിന്നുകൊണ്ട് ചെയ്യാം, കട്ടിൽ കിടക്കുന്നതാണെങ്കിൽ നിന്നുകൊണ്ട് ചെയ്യാം. പ്രിൻസിപ്പിൾ എന്താണ്? നമ്മുടെ അരക്കെട്ട് രോഗിയുടെ നെഞ്ചിന്റെ മുകളിലായി വരണം എന്നുള്ളതാണ്. അങ്ങനെയാണെങ്കിൽ എഫക്റ്റീവായ കംപ്രഷൻ വരുള്ളൂ. അത് പ്രത്യേകം ശ്രദ്ധിക്കണം. പിന്നെ ഐഡന്റിഫിക്കേഷൻ ഓഫ് സൈറ്റ്, എവിടെയാണ് കംപ്രഷൻ കൊടുക്കുന്നത്, എങ്ങനെയാണ് കൈ വെക്കുന്നത്, അതുപോലെ തന്നെ എങ്ങനെയാണ് കംപ്രഷൻ കൊടുക്കുന്നത്, ഇതൊക്കെ ഇമ്പോർട്ടന്റ് ആണ്. അതൊക്കെ നമുക്ക് പോവാം. അപ്പം കുപ്പായ കെട്ട ആളാണ്, കുപ്പായ പൊതുസ്ഥലത്ത് വെച്ച് കുപ്പായ അഴിക്കാനൊന്നും പുറപ്പെടണ്ട. അയാള് നെഞ്ചിന്റെ മുകളിൽ കൂടെ കൈ വെക്കുക. നെഞ്ചിന്റെ മധ്യഭാഗത്ത് നിന്ന് ഏറ്റവും താണ ഭാഗം സ്ഥിരീകരണം, പേരൊന്നും അവരെ പഠിപ്പിക്കണം എന്നില്ല, അടയാളം മനസ്സിലാക്കുക. അതിന്റെ മുകളിൽ ഒരു വിരൽ വെക്കുക, ഇതേപോലെ ഒരു വിരൽ വെക്കുക. എന്നിട്ട് അതിന്റെ മുകളിൽ 2 വിരൽ വെക്കുക. എന്നിട്ട് പിന്നെ കൈയിന്റെ ഉപ്പുറ്റി ഹീൽ നിറഞ്ഞ ഈ ഭാഗം വെക്കുക, മറ്റേ കൈ അതിന്റെ മുകളിൽ വെക്കുക, വിരൽ പടുത്ത് വെക്കുക. അതായത് മാറലിന്റെ ഏറ്റവും താഴ്ന്ന ഭാഗത്ത് നിന്ന് 2 വിരൽ മുകളിലായി കൈയിന്റെ ഉപ്പുറ്റി വെക്കുക, മറ്റേ കൈ അതിന്റെ മുകളിലായി വിരലുകൾ പിണച്ച് വെക്കുക. അപ്പൊ ഇങ്ങനെയായിരിക്കും. എന്നിട്ട് നിൽക്കുന്നത് എന്താണ്? ഇതേപോലെ നിന്നുകൊണ്ടാണ്. നിലത്ത് കിടക്കുന്ന പേഷ്യന്റ് ആണെങ്കിൽ ഇതേപോലെ നിന്നുകൊണ്ട് വരണം. നമ്മുടെ ചുമല് എവിടെ വരണം? രോഗിയുടെ നെഞ്ചിന്റെ മുകളിലായിട്ട് വരണം. എൽബോ കൈമുട്ട നിവർന്നിരിക്കണം. മുമ്പ് പറഞ്ഞ പോലെ വിരലുകൾ പിണച്ചു വെക്കണം. ഈ പൊസിഷനിൽ നിന്നുകൊണ്ട് വേണം ചെസ്റ്റ് കംപ്രഷൻ കൊടുക്കാൻ. ഇനിയത്തെ സ്ലൈഡ് വളരെ പ്രധാനപ്പെട്ടതാണ്. സമയമെടുത്ത് തന്നെ പബ്ലിക്കിന് പഠിപ്പിച്ചു കൊടുക്കണം. ഞാനിത് കുറച്ച് വേഗത്തിൽ പോയെന്നുള്ളതാണ്. ഇങ്ങനെ കംപ്രഷൻ കൊടുക്കുമ്പോൾ 1, 2, 3 എന്നിങ്ങനെ 30 വരെ 1, 2, 3 അല്ലെങ്കിൽ 1, 2, 3 എന്നിങ്ങനെ എണ്ണിക്കൊണ്ട് വേണം കംപ്രഷൻ കൊടുക്കാൻ. അത് എത്ര റേറ്റ് എത്രയാണ് വേണ്ടത്? നമ്മുടെ ഹൃദയത്തിന്റെ റേറ്റ് 72 ആണ്. ഇങ്ങനെ കംപ്രഷൻ കൊടുക്കുമ്പോൾ 1 മിനിറ്റിൽ 120 പ്രാവശ്യം എന്ന തോതിൽ, അതായത് 30ന്റെ കാര്യം പറഞ്ഞു, 30 കംപ്രഷൻ 15 സെക്കൻഡ് എടുക്കണം. 1 സെക്കൻഡിൽ 2 കംപ്രഷൻ എന്ന തോതിൽ കൊടുത്തുകൊണ്ടിരിക്കണം. അതാണ് റേറ്റ്. പിന്നെ ഇങ്ങനെ കംപ്രഷൻ കൊടുക്കുമ്പോൾ നെഞ്ച് പ്രായപൂർത്തിയായ ഒരാളാണെങ്കിൽ 5 സെന്റിമീറ്റർ താഴണം, 6 സെന്റിമീറ്റർ അധികമാവരുത്. 6 സെന്റിമീറ്റർ അധികം ആയാൽ എന്തുണ്ടാവാം? വാരിയലിലൊക്കെ പൊട്ടിപ്പോകാൻ ചാൻസ് ഉണ്ട്. അത് ഒരിക്കലും ഉണ്ടാവരുത്. പിന്നെ ഓരോ നെഞ്ചമർത്തലിന് ശേഷവും നെഞ്ച പൂർവ്വസ്ഥിതിയിലാണ് എന്നുള്ളത് ഉറപ്പുവരുത്തണം. ഇതും പ്രധാനപ്പെട്ടതാണ്. റീകോയിൽ അതും വളരെ പ്രധാനപ്പെട്ടതാണ്. പിന്നെ ആദ്യത്തെ കുറച്ച് മിനിറ്റുകളിൽ ഈ ചെസ്റ്റ് കംപ്രഷൻ ആണ് ഏറ്റവും പ്രധാനപ്പെട്ടത്. ഭംഗം കൂടാതെ തന്നെ നെഞ്ചമർത്തൽ തുടർന്നുകൊണ്ടിരിക്കണം. പിന്നെ അങ്ങനെ 30 കംപ്രഷൻ, രണ്ടാമത്തെ ആവർത്തി 1, 2, 3, 29, 30, രണ്ടാമത്തെ ആവർത്തി 3, 4, 5, 29, 30, മൂന്നാമത്തെ ആവർത്തി 30, നാലാമത്തെ ആവർത്തി 30, അഞ്ചാമത്തെ ആവർത്തി കഴിഞ്ഞാൽ രോഗി പ്രതികരിക്കുന്നുണ്ടോ നോക്കണം. 2 പേരുണ്ടെങ്കിൽ ഓരോ 150 കംപ്രഷൻ, അതായത് 30x5 കംപ്രഷൻ കഴിഞ്ഞാലും ആള് മാറി മാറി ചെയ്യണം. എന്തിനാ ഈ ആള് മാറി മാറി ചെയ്യുന്നത്? എന്തിനാണ്? ഒരാൾ ഇങ്ങനെ ചെയ്തുകൊണ്ടിരുന്നാല് നമ്മൾ ഡമ്മി എടുത്ത് ചെയ്തു നോക്കിയാൽ അറിയാം, കുറച്ചു നേരം കഴിയുമ്പോൾ നമ്മൾ ക്ഷീണിക്കും. നമ്മൾ ക്ഷീണിച്ചാൽ എന്താ ഉണ്ടാവുക? നമ്മുടെ കംപ്രഷൻ എഫക്റ്റീവ് ആവില്ല. നമ്മുടെ കംപ്രഷൻ എഫക്റ്റീവ് ആയില്ലെങ്കിൽ ഓക്സിജൻ വേണ്ടത്ര ആവില്ല. അതുകൊണ്ട് ഓരോ 150 കംപ്രഷൻ കഴിഞ്ഞാലും ആള് മാറി മാറി തന്നെ കംപ്രഷൻ ചെയ്യണം. ഇത് ചെസ്റ്റ് കംപ്രഷൻ നടത്തണം. ഇത് ഒന്നുകൂടി റിപ്പീറ്റ് ചെയ്യാണ്. 30 ചെസ്റ്റ് കംപ്രഷൻ ഇൻ 1 സെറ്റ്. ചാൻറ്റ് കൗണ്ട് ലൗഡ്ലി 1, 2, 3, 30 up to 30. ഇത് എന്തിനാണ്? മെയിൻറ്റെയിൻ ദ സ്പീഡ് ആൻഡ് നമ്പർ ഓഫ് കംപ്രഷൻ ഇഫ് there are more than 1 person. ഇന്റർചേഞ്ച് every 5 cycles. പിന്നെ കംപ്ലീറ്റ് റീകോയിൽ ഉറപ്പുവരുത്തണം. പിന്നെ അഡൽട്ടിലാണെങ്കിൽ 5 സെന്റിമീറ്റർ താഴണം, 6 സെന്റിമീറ്ററിൽ കൂടുതൽ ആവാൻ പാടില്ല. അങ്ങനെ 30 ഒന്നാമത്തെ കംപ്രഷൻ കഴിഞ്ഞു, രണ്ടാമത്തെ 30 കഴിഞ്ഞു, മൂന്നാമത്തെ 150 കംപ്രഷൻ കഴിഞ്ഞാൽ 5 ആവർത്തി തുടർന്നതിന് ശേഷം രോഗി പ്രതികരിക്കുന്നുണ്ടോ നോക്കണം. ഇപ്പൊ നമ്മൾ കൈ എടുക്കേണ്ട ആവശ്യമില്ല. പിന്നെ വ്യക്തി മൂവ് ചെയ്യുന്നുണ്ടോ, കഫിംഗ് ഉണ്ടോ, വോക്കലൈസ് ചെയ്യുന്നുണ്ടോ നോക്കുക. അതാണ് ചെയ്യേണ്ടത്. ചെയ്യുന്നുണ്ടെങ്കിൽ നമുക്ക് കുറച്ച് ആശ്വസിക്കാം. ചെയ്യുന്നുണ്ട്. കേൾക്കുന്നില്ലേ?
There are few people in this who doesn't understand Malayalam.
Anyway, this should be in Malayalam. The slides in the English also. Compression only life support should be in Malayalam. So I am proceeding in Malayalam for regional language. So 30x5 നെഞ്ചമർത്തലിന് ശേഷം രോഗി പ്രതികരിക്കുന്നുണ്ടോ നോക്കുക. ശരിയായി ശബ്ദിക്കോ ആംഗ്യം കാണിക്കോ ചെയ്യുന്നുണ്ടോ നോക്കേണ്ടത്. ഇതിന് 10 സെക്കൻഡിൽ കൂടുതൽ സമയം ചെലവഴിക്കാൻ പാടില്ല. പിന്നെ എത്ര നേരം തുടരണം? അത് നമ്മൾ ആരോഗ്യ പ്രവർത്തകരെ വിളിച്ചിട്ടുണ്ട്. ആരോഗ്യ പ്രവർത്തകരെ ഏൽപ്പിക്കുന്ന വരെ തുടരണം. അതല്ലെങ്കിൽ രോഗി പ്രതികരിക്കാൻ തുടങ്ങിയാൽ 1, 2 കംപ്രഷൻ കഴിയുമ്പോഴേക്കും ആള് പ്രതികരിക്കാൻ തുടങ്ങിയാൽ നമുക്ക് നിർത്താം. പിന്നെ അതേപോലെ രക്ഷാപ്രവർത്തകർ വല്ലാതെ ക്ഷീണിച്ചു പോയാല്, രക്ഷാപ്രവർത്തകർ ഇനിയൊന്നും ചെയ്താൽ നമുക്ക് റെസിസ്റ്റേഷൻ വേണ്ടി വരും എന്നുള്ള കണ്ടീഷൻ ആയാൽ നിർത്താം. ഇനി അതോ അല്ലെങ്കിൽ സ്ഥലം സുരക്ഷിതമല്ലാതായാൽ നമുക്ക് നിർത്താം. തീ കത്തിക്കൊണ്ടിരിക്കുന്ന സ്ഥലമാണ്, നമ്മുടെ അടുത്തേക്ക് തീ എത്തിയെങ്കിൽ ഈ പ്രവർത്തനം നിർത്താം. പിന്നെ ഇത് എപ്പോഴാണ് ചെയ്യേണ്ടതില്ലാത്തത്? സ്ഥലം സുരക്ഷിതമല്ലെങ്കിൽ ചെയ്യേണ്ട. പിന്നെ രോഗി പ്രതികരിക്കുന്നുണ്ടെങ്കിൽ, നമ്മൾ കൈകൊണ്ട് കൊട്ടി നോക്കിയപ്പോൾ പ്രതികരിക്കുന്നുണ്ടെങ്കിൽ ചെസ്റ്റ് കംപ്രഷന്റെ ആവശ്യമില്ല. പിന്നെ അറിയാതെ കിടക്കുന്ന രോഗിയാണ്, കുറെ എപ്പോഴാ കിടക്കണമെന്നും അറിയില്ല, റൈഗർ മോർട്ടിസ് മരവിച്ച് പോയിട്ടുണ്ടെങ്കിൽ അവരും ചെയ്തിട്ട് കാര്യമില്ല. അപ്പം ഈ കണ്ടീഷനിൽ ചെയ്യേണ്ട ആവശ്യമില്ല. ഈ കാര്യങ്ങളൊക്കെ നമ്മൾ പല പ്രാവശ്യം പറയാറുള്ളതാണ്. ഓഡിയൻസ് ഇങ്ങനത്തെ ഡോക്ടേഴ്സ് ആയതുകൊണ്ടും അതുപോലെ സമയക്കുറവുകൊണ്ട് ഞാൻ കൂടുതൽ വിശദമായിട്ട് പോകുന്നില്ല. ഇങ്ങനെ പ്രതികരിക്കാൻ തുടങ്ങിയ എന്ത് ചെയ്യണം? പറ്റുമെങ്കിൽ ലാറ്ററൽ പൊസിഷൻ, ചെരിച്ച് കിടത്തുക വേണ്ടത്. അതിന്റെ സ്ലൈഡ് വീഡിയോ ഉണ്ട്, അത് പറ്റുമെങ്കിൽ സമയം ഉണ്ടാവുകയാണെങ്കിൽ ഞാൻ കാണിക്കാം, ഇല്ലെങ്കിൽ കാണിക്കുന്നില്ല. അപ്പം ഇങ്ങനെ ചെരിച്ച് കിടത്തിന്റെ പ്രാധാന്യം എന്താണ്? ഈ അടുത്ത ക്ലാസ്സിൽ പഠിക്കും. ചെരിച്ച് കിടത്തുമ്പോൾ എയർവേ ഒബ്സ്ട്രക്ഷൻ കുറവായിരിക്കുന്നുള്ളത്. അതേപോലെ തന്നെ ആസ്പിറേഷന്റെ ചാൻസ്, വായിലുള്ള സാധനങ്ങൾ നെഞ്ചിലേക്ക് പോവുക, അതാണ് ആസ്പിറേഷൻ. ആസ്പിറേഷന്റെ ചാൻസും കുറവാണ്. അപ്പൊ എന്താ ചെയ്യേണ്ടത്? നമ്മുടെ അടുത്തുള്ള കൈ 90 ഡിഗ്രി ആക്കി വെക്കുക, എന്നിട്ട് മറ്റേ കൈ താടിയോട് ചേർത്ത് വെക്കുക, പാദം നിലത്ത് മുട്ടിച്ച് വെക്കുക. ഇത് നമ്മുടെ വീഡിയോകളിൽ കാണുന്നുണ്ട്, അതുകൊണ്ട് കൂടെ പോകുന്നില്ല. എന്നിട്ട് നട്ടലിന് ഒരു വലിയ പ്രശ്നം വരാത്ത രീതിയിൽ ചെരിച്ചെടുക്കുക. ഈ പരിപാടി, ഈ ചെരിച്ചു കിടത്തില് രോഗിക്ക് ഉയർത്തുന്ന വീണതാണെങ്കിൽ, ട്രാഫിക് ആക്സിഡന്റ് ആണെങ്കിൽ ഒരിക്കലും ചെയ്യരുത്. നട്ടലിന് ഫ്രാക്ചർ സംശയിക്കുന്നുണ്ടെങ്കിൽ ഈ പരിപാടി ഇത് ചെയ്യരുത്. പിന്നെ ഈ കോഴ്സ് കംപ്രഷൻ ഓൺലി ലൈസപ്പിന്റെ പ്രാധാന്യം എന്താണ്? ഇറ്റ് ഈസ് ഈസി ടു ടീച്ച്, ലേൺ ആൻഡ് പെർഫോം. Can be done by anybody at anywhere. No specific equipments are needed. നമ്മൾ ആർട്ടിഫിഷ്യൽ റെസ്പിറേഷൻ അത് പറഞ്ഞിട്ടുണ്ടെങ്കിൽ എന്താണ്? ചിലപ്പോൾ വോമിറ്റ് ചെയ്യുന്ന പേഷ്യൻസ് ഒക്കെ ആൾക്കാരാവും. അവർക്ക് ആർട്ടിഫിഷ്യൽ റെസ്പിറേഷൻ കൊടുക്കണം പറഞ്ഞാൽ നമുക്ക് മടി ഉണ്ടാവും. അതേപോലെ തന്നെ AED പറഞ്ഞ ഉപകരണങ്ങളൊക്കെ അതൊക്കെ നമുക്ക് അവൈലബിൾ അല്ല. AED ഇല്ല, ആംബു ബാഗ് ഇല്ല, ഞാൻ പറഞ്ഞിട്ട് റെസിസ്റ്റേഷൻ കൊടുക്കാതിരിക്കേണ്ട. നമുക്ക് 2 കൈ ഉണ്ടെങ്കിൽ ജീവരക്ഷാ പ്രവർത്തനത്തിൽ പങ്കാളികളാവാം. 2 കൈയില്ലാത്തവർക്ക് കാല് വെച്ച് ചെയ്യാൻ പറ്റുന്നതാണ്. പിന്നെ ഇൻ കാർഡിയാക് അറസ്റ്റ് അൺഇന്ററപ്റ്റഡ് ചെസ്റ്റ് കംപ്രഷൻ ആണ് ഏറ്റവും പ്രധാനപ്പെട്ടത്. അത് മുമ്പ് പറഞ്ഞ പോലെ നെഞ്ചിൽ ഹൃദയത്തിൽ ഓക്സിജൻ ഉണ്ട്, ബ്ലഡ് ഉണ്ട്, ബ്ലഡിൽ ഓക്സിജനേഷൻ ഉണ്ട്. പിന്നെ അവസാന സമയത്തും ചെറിയ റെസ്പിറേഷൻ ഉണ്ട്, കുറച്ച് ഓക്സിജൻ കിട്ടും. പിന്നെ നമ്മൾ സ്ട്രെസ് കൊടുത്തു, റീകോയിൽ എന്ന് പറഞ്ഞാൽ ആ റീകോയിലിന്റെ സമയത്തും കുറച്ച് എയർ നെഞ്ചിലേക്ക് ചെല്ലുന്നുണ്ട്. പിന്നെ കുട്ടികളാണെങ്കിൽ ഡ്രൗണിങ് ആണെങ്കിൽ ഹാങ്ങിങ്, അതിലൊക്കെ ആണെങ്കിൽ ഹൈപ്പോക്സിയ ഈസ് എ കോസ് ഓഫ് ഡെത്ത്. അതിൽ ചെസ്റ്റ് കംപ്രഷൻ മാത്രം മതിയാവില്ല, പക്ഷേ മറ്റൊന്നും ചെയ്യാനില്ലെങ്കിൽ ഇതെങ്കിലും ചെയ്യാൻ ആരും പഠിക്കരുത്. ഇനി AD കംപ്രഷൻ ഇൻക്രീസസ് ചാൻസ് ഓഫ് സർവൈവൽ ബൈ 3 times. അത് പല സ്റ്റഡിയിലും കണ്ടതാണ്. ഈ കൂടുതൽ വിശദമായിട്ട് നോക്കണമെങ്കിൽ WW CPR ഇന്ത്യ എന്നുള്ളത് കാണാം. നമ്മുടെ ട്രെയിൻ മോർ ഹാൻഡ് കഴിഞ്ഞിട്ടില്ല, ട്രെയിൻ മോർ ഹാൻഡ്സ് സേവ് മോർ ലൈഫ് എന്നുള്ളതാണ് പ്രിൻസിപ്പിൾ. ഇതിൽ ഞാൻ നോക്കാം, ഇല്ലെങ്കിൽ സൗണ്ട് വരുന്നില്ലെങ്കിൽ അവസാനം വേറെ ഒന്നുകൂടി കാണിച്ചു തരാം. സൗണ്ട് വരുന്നുണ്ടോ നോക്കൂ. ഇതിന്റെ വീഡിയോ ആണ്.
ഒരാൾ പെട്ടെന്ന്
കേൾക്കുന്നുണ്ടോ?
എന്താണ് ചെയ്യേണ്ടത്?
കേൾക്കുന്നുണ്ടോ?
സ്ഥലം സുരക്ഷിതമാണോ എന്ന് നോക്കണം. മുന്നിൽ നിന്ന് 2 ചുമലിലും തൊട്ടി എന്തു പറ്റി എന്ന് ചോദിക്കണം. ശരിയായ ശ്വാസോച്ഛ്വാസം ഉണ്ടോ എന്നും നോക്കണം. യാതൊരു പ്രതികരണവുമില്ല, ശരിയായ ശ്വാസോച്ഛ്വാസവും ഇല്ല എങ്കിൽ ആളുകളെ സഹായത്തിനായി വിളിക്കുകയും പ്രാദേശിക ആവശ്യ നമ്പർ വിളിച്ച് വാഹനം എത്തിക്കാൻ ആവശ്യപ്പെടുകയും ചെയ്യുക. പിന്നീട് ഇടവിട്ട് നെഞ്ചിലമർത്താൻ തുടങ്ങണം. ഒരു കൈയിന്റെ ഉപ്പൂറ്റി നെഞ്ചിന്റെ മധ്യത്തിൽ മറലിന്റെ താഴെ അറ്റത്ത് നിന്ന് 2 വിരൽ മുകളിലായി വെക്കുക. മറ്റേ കൈ അതിനു മുകളിൽ വിരലുകൾ പിണച്ചു വെക്കുക. കൈമുട്ട് നിവർന്നിരിക്കണം. ചുമൽ രോഗിയുടെ നെഞ്ചിന് മുകളിലായിരിക്കണം. 5 മുതൽ 6 സെന്റിമീറ്റർ താഴോട്ട് അമർത്തണം. 1 മിനിറ്റിൽ 120 പ്രാവശ്യം എന്ന തോതിൽ. ഓരോ അമർത്തലിന് ശേഷവും മാർവിടം പൂർവ്വസ്ഥിതിയിലെത്തണം. 1, 2, 3 എന്നിങ്ങനെ 30 വരെ ഉച്ചത്തിൽ എണ്ണണം. വീണ്ടും 1, 2 എന്നിങ്ങനെ 5 ആവർത്തി ചെയ്യുക. ഇത്തരത്തിൽ നെഞ്ചമർത്തൽ ഭംഗം കൂടാതെ ചെയ്യണം. രോഗി പ്രതികരിക്കുന്നതുവരെയോ ആശുപത്രിയിൽ എത്തിക്കുന്നതുവരെയോ ഇത് തുടരണം.
ഇപ്പൊ പലരും ഒരു സംശയം ചോദിച്ചേക്കാം, ഈ കോവിഡ് പാൻഡമിക്കിൽ നമ്മൾ ചെയ്യാൻ പറ്റുമോ? കോവിഡ് പാൻഡമിക്കിൽ ചെസ്റ്റ് കംപ്രഷൻ കൊടുത്താലും അതുപോലെ തന്നെ എയർവേ മാനേജ്മെന്റ് സമയത്തൊക്കെ ഇൻഫെക്ഷൻ പടരുന്നതിനും എയറോസോൾ ജനറേഷൻ പ്രൊസീജിയേഴ്സ് ആണ് വരുന്നതിനുള്ള ചാൻസ് ഉണ്ട്. അതേപോലെ തന്നെ റിസസിറ്റേഷൻ സമയത്ത് കൂടുതൽ ആൾക്കാർ ഒന്നിച്ച് വരുന്നുണ്ട്, അപ്പോഴൊക്കെ പകരാം. പക്ഷേ നമ്മൾ ചെയ്തിട്ടില്ലെങ്കിൽ എന്ത് വേണം, അയാൾ മരിക്കുന്നുള്ള സാധ്യത ഉണ്ട്. അപ്പൊ എല്ലാ മുൻകരുതലും എടുത്തുകൊണ്ട് ജീവരക്ഷാ പ്രവർത്തനം ചെയ്യണം. എന്തൊക്കെ ചെയ്യാം? നമ്മൾ മാസ്ക് പബ്ലിക് പ്ലേസിൽ ഇടുന്നുണ്ട്, ഗ്ലൗസ് ഇടുക, ഫേസ് ഷീൽഡ് പറ്റെങ്കിൽ ഇടുക, ആപ്രൺ പറ്റെങ്കിൽ ഇടുക. പിന്നെ അതേപോലെ തന്നെ രോഗിയുടെ മുഖത്ത് മാസ്ക് ഉണ്ടെന്ന് ഉറപ്പുവരുത്തണം. പിന്നെ ഈ ഗ്ലൗസ് കിട്ടിയിട്ടില്ലെങ്കിൽ നമുക്കൊരു പ്ലാസ്റ്റിക് കവർ എടുത്താൽ മതി. ഫേസ് ഷീൽഡ് കിട്ടിയിട്ടില്ലെങ്കിൽ നമുക്ക് ഹെൽമെറ്റ് ഉപയോഗിക്കാം. അതുപോലെ തന്നെ ആപ്രൺ കിട്ടിയിട്ടില്ലെങ്കിൽ നമുക്ക് റെയിൻകോട്ട് വേണമെങ്കിൽ ഉപയോഗിക്കാം. ഇത്ര ഉപയോഗിച്ചുകൊണ്ട് നമ്മൾ ഈ ജീവരക്ഷാ പ്രവർത്തനത്തിൽ പങ്കെടുക്കണം. പിന്നെ ആ രോഗിയുടെ മുഖവും നെഞ്ചും ഒരു പ്ലാസ്റ്റിക് കവർ കൊണ്ട് കവർ ചെയ്യുക, അതല്ലെങ്കിൽ ഒരു തുണി കൊണ്ടെങ്കിലും കവർ ചെയ്യാൻ നോക്കുക. പിന്നെ കോൾ ഫോർ ഹെൽപ്പ്, അപ്പൊ കോവിഡ് സ്റ്റാറ്റസ് ഒക്കെ പറഞ്ഞു കൊടുക്കണം. അങ്ങനെയാണെങ്കിൽ അവിടുന്ന് ഹെൽത്ത് ടീം വരുമ്പോൾ അവർക്ക് PPE ഒക്കെ ഇട്ട് വരാം. അതുപോലെ തന്നെ പൾസ് ഓക്സിമീറ്റർ, വൈറൽ ഫിൽട്ടർ അങ്ങനത്തെ കൊണ്ടുവരാൻ പറ്റും. എപ്പോഴും കംപ്രഷൻ കൊടുക്കും. രോഗിയുടെ മുഖത്ത് നിന്നും കഴിയുന്നത്ര മുഖം നമ്മുടെ അകത്തി വെക്കുക. സാധാരണ റെസിസ്റ്റേഷനൊക്കെ നമ്മൾ മാക്സിമം ആൾക്കാരുണ്ടാവണം എന്നാ പറയാ. ഇതിലാണെങ്കിൽ കഴിയുന്നത്ര ആൾക്കാരെ കുറച്ച് വേണം ചെയ്യാൻ. ഇത് കഴിഞ്ഞിട്ട് നമ്മൾ ഒരു ഹാൻഡ് ഓവർ ചെയ്ത് കഴിഞ്ഞു ഹെൽത്ത് ടീമിനെങ്കിൽ അതിനുശേഷം നമ്മുടെ ഡ്രസ്സൊക്കെ സ്റ്റെറിലൈസ് ചെയ്യണം. പിന്നെ നന്നായി സോപ്പിട്ട് കഴുകുകയും വേണം. പിന്നെ ഇപ്പോഴും പറഞ്ഞത് ഞാൻ അഡൾട്ടിന്റെ കാര്യമാണ്. കുട്ടികളുടെ കാര്യത്തിൽ വിശദമായിട്ട് ഇന്ന് അവസാനത്തെ ക്ലാസ്സുകളുണ്ട്. അതിൽ അഡൾട്ട് തുടങ്ങിയ 8 വയസ്സിന്റെ താഴെയുള്ളവർക്കെല്ലാം അഡൾട്ട് ചെയ്ത പോലെ ചെയ്താൽ മതി. കുട്ടി 1 വയസ്സ് മുതൽ 8 വയസ്സ് വരെ ആണെങ്കിൽ അഡൾട്ട് നമ്മൾ പറഞ്ഞത് 5 മുതൽ 5 സെന്റിമീറ്ററിന് മുകളിൽ 6 സെന്റിമീറ്റർ താഴെയാണ്. കുട്ടികളിലാണെങ്കിൽ അപ് ടു 5 സെന്റിമീറ്റർ ചെസ്റ്റ് കംപ്രഷൻ കൊടുക്കുക. അതുപോലെ ഇൻഫന്റ് എന്ന് പറഞ്ഞാൽ 1 ഇയറിൽ താഴെയാണെങ്കിൽ 4 സെന്റിമീറ്റർ ചെസ്റ്റ് താണാൽ മതി. അതല്ലെങ്കിൽ 1/3 ഡയമീറ്റർ ഓഫ് ദ ചെസ്റ്റ് ഇങ്ങനെ കൊടുത്താൽ മതി. ഇത് മാത്രം മതിയാവും എന്നുള്ള ചോദ്യം ചോദിക്കും. അതിന്റെ അടുത്ത ക്ലാസ്സുകളിൽ അതിന്റെ ഉത്തരം വരും. കുറച്ച് നേരത്തേക്ക് ഇത് മാത്രം മതിയാവും. കുറച്ച് കഴിഞ്ഞാൽ അത് മാത്രം കുറച്ച് നേരം കഴിഞ്ഞാൽ അത് മാത്രം മതിയാവില്ല. പിന്നെ എന്ത് വേണം? ഓക്സിജനേഷൻ വേണ്ടി വരും. അത് പക്ഷേ നമ്മളെ പബ്ലിക്കിനെ പഠിപ്പിക്കുന്നില്ല, പബ്ലിക് ട്രെയിനിങ്ങിൽ പഠിപ്പിക്കുന്നില്ല. ഇതേപോലെ എയർവേ മാനേജ്മെന്റും ആർട്ടിഫിഷ്യൽ റെസ്പിറേഷനും അത് അടുത്ത ക്ലാസ്സുകളിൽ പഠിക്കും. അതേപോലെ തന്നെ AED അതിനെക്കുറിച്ചും പഠിക്കും. അതൊക്കെ ഉപയോഗിച്ച് കൂടുതൽ എഫക്റ്റീവായ രീതിയിൽ കൊടുക്കേണ്ടി വരും ഹെൽത്ത് കെയർ ടീം വന്നാൽ. പിന്നെ പലരും വലിയൊരു പ്രശ്നം പറഞ്ഞത്, ഇങ്ങനെ ക്ലാസ് എടുക്കുമ്പോൾ ഞങ്ങൾ സ്കൂളുകളിലേക്ക് പോകുമ്പോൾ എങ്ങനെയാണ് മാനിക്കിൻ വരിക എന്നുള്ളത്. ഇപ്പൊ മാനിക്കിനൊക്കെ ഏറ്റവും കുറഞ്ഞ മാനിക്കിന് പോലും 8,000-10,000 രൂപ വരും. അപ്പൊ നമ്മൾ ഒരു ടീച്ചർമാരുടെ ഇടയിൽ നിന്ന് വന്നൊരു സൊല്യൂഷൻ ആയിരുന്നു 6 ഇഞ്ച് കനമുള്ള ഒരു സ്പോഞ്ച് എടുത്ത് വെക്കാം, ഇങ്ങനെ ആക്കിയാൽ മതിയോ എന്ന് അവർ ചോദിച്ചതാണ്. ഞാൻ നിങ്ങളുടെ എല്ലാ അഭിപ്രായം അറിഞ്ഞ ശേഷം മാത്രമേ അതിനൊരു മറുപടി കൊടുക്കുന്നുള്ളൂ. ഇതേപോലെ കംപ്രഷൻ കൊടുത്താൽ മതിയോ എന്നുള്ളൊരു ചോദ്യം. 6 സെന്റിമീറ്റർ കനമുള്ള സ്പോഞ്ച് എടുത്ത് ഇതേപോലെ ആക്കിയിട്ട് കംപ്രഷൻ കൊടുത്താൽ മതിയോ എന്നുള്ളത്. പിന്നെ പലപ്പോഴും പൊതുജനങ്ങൾക്ക് വളരെ സംശയം ഉണ്ടാകുന്നതാണ് റിസസിറ്റേഷനും അതുപോലെ ട്രോമയുടെ കാര്യത്തിലൊക്കെ സംശയം ഉണ്ടാകുന്നതാണ്. എപ്പോഴും ഹോസ്പിറ്റൽ അറ്റാക്സ് ഒക്കെ വരുന്നത് ഇതിന്റെ പേരിലാണ്, ഹോസ്പിറ്റലിൽ കയറി കിട്ടിയിട്ടില്ല എന്നുള്ള പേരിലായിരിക്കും. ഇത്തരം സന്ദർഭങ്ങളിൽ പൊതുജനങ്ങളെ പബ്ലിക് അവയർനെസ് ക്ലാസ്സുകളെ പൊതുജനങ്ങളെ ബോധവാന്മാരാക്കുന്നതിന് കൂടി നമ്മൾ ഉപയോഗിക്കണം. പിന്നെ റിസസിറ്റേഷൻ, പ്രത്യേകിച്ചും ട്രോമയുടെ കാര്യത്തിലാണെങ്കിൽ റിസസിറ്റേഷൻ വന്നിട്ടുണ്ടെങ്കിൽ അത് മരിച്ചിട്ടുണ്ടെങ്കിൽ അവരോട് പറഞ്ഞു കൊടുക്കാൻ, അവരെ ബോധവാന്മാരാക്കണം. മരണാനന്തര അവയവദാനം എന്ന് പറഞ്ഞ ഒരു പരിപാടി ഉണ്ട് എന്നുള്ളത് അവരെ പറഞ്ഞ് മനസ്സിലാക്കി കൊടുക്കണം. അതിനെക്കുറിച്ച് ഞാൻ ഇപ്പൊ കൂടെ പറയാൻ സമയക്കുറവ് കൊണ്ട് പോകുന്നില്ല. അടുത്ത ദിവസം ക്ലാസ്സിൽ സമയം ഉണ്ടെങ്കിൽ അതിനെ പറഞ്ഞു കൊടുക്കാം. അത് നമ്മളിപ്പോ ആരോടും പറയാറില്ല. പക്ഷേ പൊതുജനങ്ങള് പണ്ട് ബ്ലഡ് കൊടുക്കണം എന്ന് പറഞ്ഞാൽ ആൾക്കാർ ഓടിപ്പോയായിരുന്നു. ഇപ്പൊ അതല്ല സ്ഥിതി. 2 കുപ്പി വേണമെന്ന് പറഞ്ഞാൽ അവർ 20 ആളെ വേണമെങ്കിൽ കൊണ്ടുവന്ന് വരും. അതേപോലെ പബ്ലിക് ഓർഗൻ ഡൊണേഷൻ തയ്യാറായിട്ട് വരികയാണെങ്കിൽ നമ്മൾ അത് ചെയ്തു കൊടുക്കുന്ന കൂടി അവരെ പറഞ്ഞു കൊടുക്കണം. ഈ പറഞ്ഞ കാര്യങ്ങളെല്ലാം ഇന്ത്യൻ ജേർണൽ ഓഫ് അനസ്തീഷ്യ ഒക്ടോബർ 17 വന്നതാണ്. പിന്നെ ഇത് ഇന്നും ഈ ക്ലാസ്സുകളും അതുപോലെ ഇനി വരാനുള്ള ക്ലാസ്സുകളും ഒക്കെ നമ്മുടെ ആരോഗ്യത്തിന് പല പ്രാവശ്യമായിട്ട് വന്നതാണ്. നമ്മുടെ ആരോഗ്യത്തിന്റെ പബ്ലിക്കേഷൻ റേറ്റ് കൂട്ടുന്നതിനും അതുപോലെ ആൾക്കാർ കൂടുതൽ എത്തിക്കുന്നതിനും ഈ നമ്മുടെ പബ്ലിക് ബോധവൽക്കരണ ക്ലാസ്സുകൾ ഉപയോഗിക്കണം എന്ന് കൂടി അഭ്യർത്ഥിക്കുകയാണ്. ഞാൻ അല്പസമയം കൂടുതൽ എടുത്തു തോന്നുന്നു. നമ്മുടെ എയിം എന്ന് പറഞ്ഞാൽ എവരി സിറ്റിസൺ എ ലൈഫ് സേവർ എന്നുള്ളതാണ്. അത് പ്രാവർത്തികമാക്കാൻ നിങ്ങളുടെ എല്ലാവരുടെയും സഹായം ഉണ്ടാവണം. ഇത് കഴിഞ്ഞാൽ നിങ്ങൾ എല്ലാവരും ബ്രാഞ്ചുകൾ ലെവലിൽ മീറ്റിംഗ് നടത്തണം. ഹെൽത്ത് കെയർ വർക്കേഴ്സിനെ പഠിപ്പിക്കണം. അവരുടെ സഹായത്തോടെ പബ്ലിക്കിനെ പഠിപ്പിക്കണം. പ്രത്യേകിച്ച് ടീച്ചർമാരെ പഠിപ്പിക്കണം. ടീച്ചർമാരുടെ സഹായത്തോട് കൂടി മാത്രമേ നമുക്ക് എല്ലാ കുട്ടികളെയും എത്തിക്കാൻ പറ്റൂ. ഈ കോവിഡ് ഒക്കെ മാറി ഒരു കാലം ഉണ്ടാവുകയാണെങ്കിൽ നമുക്ക് ചെയ്യാം. ഒരു ദിവസം 25 ലക്ഷം 5, 6, 8, 9, 10, 11, 12 ക്ലാസ്സുകളിലെ എല്ലാ കുട്ടികളെക്കൊണ്ടും കംപ്രഷൻ ഒരു ദിവസം. അതുകൊണ്ട് ആര് രക്ഷപ്പെടുന്നല്ല, ഒരു അവയർനെസ് ഉണ്ടാക്കാൻ വേണ്ടി ചെയ്യാം. അതിനുവേണ്ടി എല്ലാവരുടെയും സഹായ സഹകരണങ്ങൾ പ്രതീക്ഷിക്കുന്നു. താങ്ക് യു ഫോർ giving me the opportunity. Thank you. Paul.
Thank you, sir. Thank you for that deliberation. And for those who actually few of them like one had sent a direct message. Like those who didn't understand about the Poles is a compression only lies where there is only the compression in that. And we have to teach the public in Malayalam. That is the reason why Shashi sir has taken so much pain to convert into Malayalam and speak. So there is no point in the layperson to tell him to check the pulse. There is no point at all, because even for us doctors, it is not possible to check the pulse and know whether it is our pulse and or the patient's pulse. And this has to be done in 5 seconds to 10 seconds. So it's not possible. And what they have studied is that in compression, if you do just compression alone, there is survival. That is the message what is giving. Now the next talks will be for the people, for those who are paramedics as well as the medics, so that they will be able to appreciate the pulse and see. So first thing that the talk will be, we will be adding the airway management also to this what Shashi sir has spoken. So for that I call Dr. Brijesh, the assistant professor of MES Medical College, to speak on airway management in patients. Thank you. Thank you, Shashi sir. Dr. Brijesh? Dr. Brijesh is there?
Brijesh.
Dr. Brijesh. Okay, then we'll go to the next talk. Brijesh is there? Can somebody from Malappuram just find out? Or is muted?
Yes.
Yeah. Brijesh.
Yes, sir. Sir, can you see my slide?
Yes.
Yes.
Very much.
Yes, thank you, sir. So, good evening, all. Respected national and state leaders, senior members, the various office bearers, let me thank you for giving me this opportunity. And let me go to the topic as quickly as possible. When we were students, we were taught the basics of resuscitation was A, B, and C. Airway, breathing, and circulation. So A was first, B was second, and C was third. Now, the recent trend, after various studies all over the world, it has changed to C followed by A and B. So circulation comes first. So naturally, airway and breathing takes a backseat. With that, I will start my talk. So Shashi sir already explained the 3 resuscitation guidelines by ISA and Indian Resuscitation Council. The calls for the layperson has already been explained in detail by Shashi sir. The other 2 are for the trained paramedics and medics. The BCLS is for those when it happens outside the hospital, whereas the CCLS is the protocol which we have to follow when we are inside the hospital. So in these 2 protocols, so we saw in calls, there is no reference of airway or breathing because you cannot teach them well. For a layperson, it's very difficult. But that is not the case for us. That is the paramedics as medics who are trained in this. So what are we supposed to do regarding the air? That is the question. So in both the left, you can see the green BCLS guidelines and the right, the blue, the CCLS guidelines. Both guidelines, we start with breathing and airway from checking the breathing and carotid pulse. So once you find that the patient is non-responsive, you shout for help and start checking breathing and carotid pulse simultaneously, not more than 10 seconds and not less than 5 seconds. So between 5 and 10 seconds. So I am focusing on the management of airway and breathing. So while simultaneously checking for the carotid pulse, you scan the chest and abdomen and look for signs of breathing. Assume the victim to be in respiratory arrest if there is absent breathing, abnormal breathing like gasping or agonal breaths, an abnormal and often brief and inadequate pattern of breathing, which is called agonal breath, or if you cannot determine whether you are doubtful, you assume that the victim is in respiratory arrest. So in resuscitation, how is it? You need a patent airway and the breath which carries oxygen into the lungs, and oxygenation of the blood inside the lungs, and circulation of this oxygen-containing blood to the tissues and tissue perfusion. So here we are talking about airway and breath, which goes together. So airway management can broadly be classified as basic airway management techniques and advanced airway management techniques. So I will be focusing more on the basic airway management techniques first, and to some extent, some advanced airway management techniques, which needs more training. So what is this basic airway management technique? It includes the manual relief of upper airway obstruction using the triple airway maneuver, which we will talk later, and ventilating the patient using a bag and mask, or techniques like mouth to mouth or mouth to mask. And if there is still airway obstruction, you can use some basic airway adjuncts like an oropharyngeal airway or nasopharyngeal airway. Remember, all healthcare professionals should be well versed with basic airway management, as it is crucial for maintaining airway patency and providing breaths. Which is the most common cause of airway obstruction. And we should know that it is the fallen back tongue, as you can see in these pictures. So when the tongue falls back, as you can see in these pictures, it will obstruct the airway, whether it is through the nose or through the mouth, it will obstruct the airway. So it will prevent the airway from going down to the trachea and lungs. So The first technique is to open the airway. Only through an open airway, the breath can go in and breath can come out. So, airway, how do we open the airway? You have a technique, something called head tilt and chin lift. How do you do that head tilt, chin lift maneuver? Follow these steps. With the patient supine, position yourself beside the patient's head. You can see that picture there. Place the heel of one hand on the forehead. Apply firm backward pressure with the palm. That is the head tilt. Place fingertips of the other hand under the lower jaw and lift the chin. Lift the chin upward with the entire lower jaw. And remember, you should not do this when there is a suspected cervical spine fracture. As Sir told earlier, you can aggravate a cervical spine injury and cause a quadriplegia. So in suspected such cases, you use a different technique, which is called the jaw thrust maneuver. If you have a suspected cervical spine injury, use jaw thrust maneuver. Follow these steps. Again, you can see the picture. Kneel above the patient's head. Place your finger behind the angles of the lower jaw. Move the jaw upwards. Use your thumb to help position the jaw. You can see the picture. So, suspected cervical spine fracture, important, very, very important. No head tilt. Use jaw thrust and manual spinal motion restriction, manual inline motion restriction techniques. So the second person is holding the, from the side, you can see it here. The one person is giving the jaw thrust and the other person is giving the manual spinal motion restriction so that the cervical spine is not moving. So the chance of cervical spine injury is reduced. Now, you have maintained the patency of the airway using the triple maneuver, the head tilt chin lift maneuver or the jaw thrust maneuver. Now you have to deliver the breath. How do you deliver the breath? It can be mouth to mouth. We have learned that term even from our school days, or mouth to mask, or more advanced back and mask. For doctors and paramedics, that may be the best method. So in the here in this picture, you can see a person giving a mouth-to-mouth breath. See, with his one hand, he is gently lifting the jaw, chin up. With this hand, ulnar portion, he is giving slight head tilt. Then with the same hand, using the thumb and the index finger, he is closing the mouth. He is taking a deep breath in, approximating his mouth to the patient's mouth. With his exhaled air, he is blowing that into the open mouth of the victim. And he is looking for the rise of the chest. But in scenarios like COVID, as Sir told, or even some people do not like to put one's mouth to other person's mouth for other reasons, or it's less hygienic where there is vomitus or blood, you can use something called a CPR face shield so that direct contact is avoided. So it is hygienic for both the rescuer as well as for the victim. Or better, if you have got a pocket mask, you can blow your breath, exhalation breath into the pocket mask. So you can call it mouth to mask technique. So again, that is also better because it avoids direct contact. And for medics and paramedics who have this opportunity, who have this is a bag and mask. All must be aware. So here is a mask and here is a bag. Some bags have facility to have connection to oxygen. So if such a thing is available, you can use this bag and mask. And that is the one which is better recommended. So you should be able to know how to use this bag and mask. Okay, how will you put the mask on the face? So the mask, it has got an apex of the mask. It should be placed over the bridge of the nose, and the base of the mask should be over the chin. The position of the patient, the victim, should be supine, and the rescuer on the head edge. You can see it here. And Compress the mask with the thumb and the index finger, forming a C, you can see here. And elevate the jaw, bony part, with the remaining 3 fingers forming the letter E. So you call it a C and E techniques. So the same thing is shown in the other figure, the pictures also, so that you can appreciate that. So how will you hold the mask? So C and E technique, you know that. So either you can hold it with one hand. If not possible, you can use both hands. Then you have the other, you should have the second person to hold the bag and squeeze it. So when you squeeze the bag, the whatever air is in, it will go into the mask and into the airway of the victim. So that is the preferred, bag and mask is the preferred device giving breath when more than one rescuers are present. So again, another picture showing the C and E technique, C and E technique for holding the mask along with the bag. Okay, you have the bag and mask. How much breath you should give and what should be your endpoint. So there is a bag and mask, 1 breath every 5 seconds. So patient is currently having a respiratory arrest only. There is no cardiac arrest. So heart is pumping. Okay, so now only respiratory arrest. So 1 breath every 5 seconds and each breath over 1 second. Endpoint is a visible chest rise. A normal tidal volume breath should be provided. C, only a normal tidal volume breath with visible chest rise. No high rate ventilation, not more than 12. So when you hyperventilate, there are problems. It can be detrimental for survival of the patient. So do not hyperventilate, neither rate or volume. So that is a very important point in managing the airway and breath. So in the other condition, when you have a cardiac arrest also, so what initially we saw was respiratory arrest alone. Now, when you have a cardiac arrest also, the chest compressions take precedence. So 30 chest compressions followed. Say about chest compressions, we are going to hear that again in detail, and that is the most important part of resuscitation, followed by 2 rescue breaths. How do you give rescue breaths? Each breath over 1 second and 1 second for expiration. 2 breaths, each breath over 1 second and 1 second pause after first breath. And after you give the second breath, you immediately start the chest compressions again without delay. That is very important. So you can use mouth to mouth or mouth to any barrier device or mouth to mask, or if available, bag and mask. That is the best. Do not interrupt chest compression unnecessarily. And endpoint is again visible chest rise, normal tidal volume breath, no hyperventilation. So using a bag and mask, how can you practically give a ventilation? So give first breath over 1 second and chant 1001. So that means 1 second. So if you chant 1, that will not take you for 1 second. So if you chant 1001, definitely that is 1 second. And release the bag and chant 1000. So the second. And give the second breath over 1 second. Chant 1003. That is another 1 second. Release the bag and start chest compression. So total time for 2 rescue breath is only 3 seconds. Continue chest compression. There are certain basic airway adjuncts which can be used if available, especially in a hospital setup, like an oropharyngeal airway or a nasopharyngeal airway. You might have seen them. So we saw that the most common cause of airway obstruction is a fallen back tongue. Either oropharyngeal airway, which is put through the oral cavity, which bypasses the tongue to reach the glottic opening. So you have to choose the appropriate size of oropharyngeal airway, because if it is too small, it won't serve the purpose. If it is too large, that itself can obstruct the air. So you have to choose the appropriate size. So roughly from the midpoint of the patient's incisor to the angle of the mandible of the incisor, you can see this figure. He's looking which size may be appropriate. So you have to use the appropriate size of the oropharyngeal airway when you use it. So how do you insert it? You insert an oropharyngeal airway upside down, as you can see here. Once you reach halfway, you can turn 180 degrees behind the tongue, and the flanged end, this is the flanged end, should sit just in front of the teeth, like this. The problem with oropharyngeal airway is that if the patient is conscious or semi-conscious, he may vomit or precipitate laryngospasm. So you should be careful when you use oropharyngeal airway. Another thing is nasopharyngeal airway, which is put through the nose. As we know, even though the openings of nose and mouth are different, posteriorly they meet. So again, the appropriate size of nasopharyngeal airway is important. It is approximately from the lateral edge of the nostril till the tragus of the ear. Here you can see a nasopharyngeal airway inserted and bypassing the tongue and relieving the obstruction of the airway. Again, there are some problems when you use nasopharyngeal airway. Severe head injury with blood in the nose or history of fractured nasal bone, probably your nasopharyngeal airway may go into the brain. So you should be careful, or you should avoid in such situations. So again, even though I am talking about airway and breathing, regarding ventilation and airway, do not unnecessarily interrupt chest compression for securing the airway. That is very important. Do not hyperventilate. That will deteriorate the quality of your chest, your resuscitation. And end point of ventilation is a visible chest size, normal tidal volume breath. I am repeating it again so that it goes into your head, so you will remember always. And once the patient starts normal breathing, you can turn the patient to the recovery position, about which Shashi sir talked a bit earlier. So here you can see. So that will help. This recovery position will help the patient's tongue to fall back, will prevent from the tongue falling back again and obstructing. Or if some secretions or blood or vomitus is there, it will fall away from the patient's mouth and airway so that it will not obstruct. So here you can see he is sitting on the left side of the patient, and he is turning the patient towards the left side with the right hand behind the left cheek and the right foot folded. This is called the recovery position. So when you transport it, or even when the patient is recovering, you can, if there are no contraindications like suspected fracture spine, you can put the patient in the recovery position. So it has got certain advantages. That is the point. Now coming to the advanced airway management. Remember, if you do not know advanced airway management, nothing wrong in it. Okay, it needs much more skill to learn. Okay, if you know it, very good. That's very good. But if you do not know it, that doesn't mean that you cannot take part in resuscitation. You can definitely, because it is, as I said earlier, it is the oxygenation and ventilation which is important, not intubation. Okay, so intubation, ventilation you can achieve with your bag and mask or mouth to mouth with your triple airway maneuvers. So you can open the airway and give breath if needed. So you need not hurry about advanced airway adjuncts like laryngeal mask airway, laryngeal tubes, or either endotracheal. So broadly, it can be classified at those things which go beyond the glottis into the trachea, that is an endotracheal tube, or the things which comes above the glottis, that is supraglottic airway devices. So the two goals of advanced airway management is better and definite control of oxygenation and ventilation, airway protection from aspiration of vomiters, secretions, blood, or gastric contents. You can see these are pictures of a classical LMA, if you have not seen one. And this is some more advanced airway device like iGel. So the use of supraglottic airway device also advocated if rescuer is appropriately trained, and sometimes endotracheal tube placement is not feasible or successful. So it's a part of advanced airway management. And the most definite airway is still the gold standard is endotracheal intubation. It is a definite skill which has to be learned. Perhaps I will skip. It needs training, perhaps through a mannequin, which I hope every one of you will get someday during your training sessions. And the important things to look when you manage endotracheal intubation is you have to have a good suction, then oxygen, the airway equipments like laryngoscope ready, the proper positioning of the patient, the appropriate monitors, and the esophageal. If sometimes it may go into the esophagus instead of trachea, because both tubes, the trachea and the esophagus are, one is above and one is below. Sometimes it goes to the esophagus. It can be catastrophic. So you should prevent it going to the esophagus. So you should detect esophageal detection device and proper arrangement and the check functioning of all these equipments. So this slide I will slip. This is how you intubate a trachea. And regarding advanced airway devices, if the bag and mask ventilation is optimal, then securing definite airway can be deferred. So that is not an urgent thing. If bag and mask ventilation is okay, and you do not have the expertise to put one endotracheal tube, that's okay. You continue with your bag and mask ventilation. To prevent unnecessary interruption of chest compression, sometimes you give too much importance to endotracheal intubation, and you will forget the most important thing, chest compression. So that should not happen. In such cases, the bag and mask ventilation should be continued till expert help arrives. So these are a few drugs which aids endotracheal intubation during resuscitation, which include midazolam or midazolam with fentanyl or ketamine, and in expert hands, use of muscle relaxants like succinylcholine and rocuronium. In difficult airway situations, you cannot properly hold the mask or cannot intubate such cases. So you should not look startled and you do not know what to do. No. Chest compression should never be stopped for the difficult airway assessment or management. So whatever is the situation, you can continue chest compressions because the circulation of blood, some amount of oxygen will reach the tissues. So it is better than nothing. So continue with bag and mask ventilation combined with chest compression till expert help arrives. So supraglottic airway devices should be promptly inserted or maintained for oxygenation and ventilation. So intubation is not a must. It is not the only solution. So you need expertise, you need training to put an supraglottic airway device, you need training to put an endotracheal tube. But even without that, you can manage your airway. And sometimes situations can come like you cannot intubate and you cannot even ventilate. There are certain situations. So there is still, experts say there is something called apneic oxygenation. You put high flow oxygen through face mask. Some amount of oxygen will be going passively into the trachea and into the lungs. So that will help. That will help to delay the catastrophe. And you can continue with just compression only life support course. If experts are there, you can do a surgical cricothyroidotomy, front of neck access, you call it, for life saving. Synchronizing the chest compressions. So you said 30 chest compressions and 2 rescue breaths. So sets of 30 chest compressions and 2 rescue breaths when there is cardiac and respiratory arrest. There is cardiorespiratory arrest till advanced airway is placed. Once an advanced airway is placed like an endotracheal tube, you need not synchronize like 30 to 2. So the chest compression can continue without break while rescue breath can be given 1 breath every 6 seconds without synchronizing. Okay, breath will happen in its own synchrony and chest compression will happen on its own rhythm. Your tomorrow, next day, coming day, you are definitely going to hear more about trauma and all these things. But I thought I will talk something about airway and trauma. So when we all in casualties, we come across these trauma patients. So when airway intubation must be considered when there is hemodynamic instability related to trauma, when systolic blood pressure less than 90, or there are signs of respiratory failure and tachypnea is there, more than 29 breaths per minute, you should consider possibly intubating early so that you can get the help early. And absolute indications of intubating in a trauma patient include apnea, or gasping, or when hypoxia is shown less than 90% without signs of tension pneumothorax, and severe traumatic brain injury, GCS less than 9. Again, I tell you, if you cannot do an intubation, continue with your chest compression and bag and mask ventilation till expert help arrive. You have got something to do. So, regarding the airway management during resuscitation, the goal is to ensure a patent airway and oxygenation, not intubation. So, in resuscitation, circulation is the main thing. Circulation followed by airway and CAB, that is the current protocol. And chest compression should either not be interrupted at all. Chest compression should not be interrupted as far as possible, or if at all interrupted, it should be less than 10 seconds, even for doing your airway management. Thank you.
Thank you, Brijesh, for a very good talk, and you explained well the things of what is required in the airway management. Next, what we will do is
your topic.
Hello. Yeah.
Hello, sir.
Your topic. For your topic next.
It is. See, what we are seeing now is about the compression only life support, and when you go further, then about the airway management also. That is what we have seen. So that is required for a basic cardiopulmonary life support also. So I will be speaking about a single Rescuer Cpr. And you should understand the issue, what is happening in India. If you see this video, you can watch a cricket match being done. That was in Hyderabad. 100 of people are watching this. If you look at the focus the bowler here, when he is going to ball the nest, he is just collapsing. That is cardiac arrest. And you see a lot of people running around and trying to lift up, and this black t-shirt guy, he suddenly remembers something, and he goes, and what he's doing is sprinkling water. This is what usually people are doing. So you may think that this happens in those who are illiterate and things like that, but if you can see this in educated people also, what is happening. And the end result of that was they couldn't save that boy who was bawling. Now, if you look at this, this is a video where a manager, Bank of Baroda, his name is Pradeep Nayar, he is leaving and he's doing a send-off. In a send-off, he is trying to speak, and you can see his wife sitting next to him, his daughter, and the other officials, all are educated at a very high level, and suddenly he gets confused. Then he is not able to focus, and the words were not coming, and he just collapses. His wife is taking water, daughter is getting up, and like this blank screen, the end result is they couldn't save. So this is what is happening. And if you see in India, the statistic which I already told, in 100,000 people in India, 4,280 people are dying of cardiac arrest. But you see in USA, it is 60 to 150. So that is the difference what we see. You would have seen recently also in the World Cup, they are resuscitating a player, which we were all seeing, because all of them know what to do. But in India, the situation is those are going abroad, they are taking this training. Others are not doing. But now in 9th standard, they have introduced in the class books, in the CBSE class book, a chapter on colds. So the idea behind is that it should reach every person, citizen. And if you see 70% of the out of hospital cardiac arrest is occurring at home, and 90% of them are dying. As I told you, it is not the doctor, nurses, or paramedics who are supposed to treat. You won't get these people. It has to be a family member. So every family member should be trained. And for this, the guidelines have come, the Indian Resuscitation Council guidelines, they made it free for the public and guidelines. And that is what we are speaking. And he's the man who spoke to you before, Dr. Chakra Rao, who is the man behind bringing out this resuscitation guidelines. So the primary concern, you all may be thinking it's the heart, it's not, it's the brain, as Dr. Shashi sir has told. And if you don't intervene within few minutes, there will be irreversible brain death. So in fact, it's very important here. And so you should have the knowledge, the presence of mind and the skill to manage these cases within this stipulated time. And this has been already been shown to you. We are repeatedly showing the guidelines so that it will be, it will become more familiar. If you see the yellow color, that is a compression only life support for the lay person. The green, that's the basic cardiopulmonary support, that is for the trained and paramedics and medics outside the hospital resuscitating a cardiac patient, and a trained paramedics and medics for treating a cardiac arrest patient inside the hospital. We have comprehensive cardiac life support. And these are color coded. As I've told you, all these algorithms are color coded and easy to understand and easy to recognize. So they have made it very simple. And I will be speaking on this basic cardiopulmonary life support, in that single rescuer, and that is for the trained personnel outside the hospital. And manuscript you can download from the IJA, which is easily downloaded. So if you look at the core links of this, like first one, as you all know, that it's early recognition and activation of the emergency when you know that it's a cardiac arrest. So early recognition, you should know this is cardiac arrest. That is important, and activation of emergency response system. Immediately you should start the high quality CPR. That is important. And early defibrillation, what they have seen is that survival is much better if you do it immediately. And within 1 minute, they say the survival after every minute which pass beyond the arrest without a defibrillation, 10% of the survival rate decreases. So you should immediately do early defibrillation and early transfer to the hospital. So you may be in one of these scenarios where you observe a person suddenly collapsing in front of you, or somebody is already collapsed when you saw him or her first, or you have arrived at a scene where a layperson is providing CPR. So that is the situation, one of the situations you will be in. And that is the algorithm for that. That's green color, and it is basic cardiopulmonary life support. As Dr. Shashidharan sir has already mentioned about the safe, whether you have to see whether you are safe and the patient is safe. So which are the unsafe areas where there is fire in middle of the road, burning car, the inhalation of poisonous gases, electrocution, etc. So these places, see, you have to be careful. You have to see your life also. That is most important, and you have to take the patient to a different place and do. Check the response. He has already mentioned. Shoulders from the front and ask, hello, how are you? If there is any verbal response or purposeful movement, you tell them responsive. And if they are responsive, you monitor them from another 2 minutes. You don't know whether they will go for an arrest further. So you observe the victim, put in the patient in the recovery position, which you are all familiar with, and shift to the nearest hospital. So that is green. If you look at the color also of that thing, that is green. That's a green signal, but this is red. So here, when there is no response, you have to shout for help. You have to call 108. That is the number you have, and all should know about this number. And the advantage of this, another team will arrive with a defibrillator or an AED to help you. So you have to shout for help. And see, when you shout for help, what are the things you are going to tell when you call in your mobile and say, it should be very specific. You identify yourself, identify your location so that the ambulance can reach you immediately. Tell them about the victim's condition, how many victims are there, so they can bring more team with you, age, sex, complaint, and general condition. These are the things you should tell through the phone. Everyone has a mobile phone with them. Then you simultaneously you check the breathing while palpating the carotid pulse. So this is not lay person. We are not saying about that you know. Now this for the paramedics or medics to resuscitate outside. You are asking them to check the pulse, and it has to be within 5 to 10 seconds. Everybody know where you have to palpate, locate the carotid prominence and trachea, slide into the groove between the trachea and neck muscles, and that should be on the same side, and palpate for 5 to 10 seconds. Simultaneously, you scan the chest and abdomen for breathing. So you will come into one of these three conditions. There will be either a normal breathing with a definitive pulse, with a definitive, then you have to see if it is responsive, then you are keeping them in recovery position. What you see is there is no, when there is no breathing and there is a pulse, then you provide one breath every 5 seconds and reassess every 2 minutes. And third condition maybe no pulse and no respiration. So this has been, for those who have to provide breathing, this has been already spoken to you by Dr. Brijesh at chin lift. Those who have suspected cervical fracture, you have to go for jaw test. And these are the things what you can do either to the mouth to mask. If you are alone, it is mouth to mask. It is back mask ventilation is when there are two rescuers. So I'm talking about the single rescuer. And the end point, what you have to see is visible chest rise, whether the chest is moving, chest rise is there, and you are providing one breath every 5 seconds. That comes to 12 breaths per minute. The third condition, which I told you, there is no pulse and no respiration. So you should start chest compression immediately with 30 compression, as Dr. Shashi sir has told you in the colds. That is the that should be the way you should be. But after 30 compression, you should give 2 breaths. So 30 compression, that will take 15 seconds approximately, and 2 breaths that Dr. Brijesh told, each breath over 1 second, and 1 second for aspiration. So another second will go for aspiration. After that, you give one more breath over 1 second. So that is almost 3 seconds, and immediately you are starting the chest compression again. So 30 compressions and 30 compressions and 2 ventilations. Then continue for 5 cycles, 30 compression and 2 breaths. Then you reassess the patient. Check the carotid pulse by reassessing whether it is there or not. If the pulse is there, then you go to the inner side. And if it is absent, again continue 5 cycles with 30 compressions and 2 breaths. Now continue this until somebody is coming with a defibrillator. Details of AED, that is automated external defibrillator. It will give you, it will identify the rhythm and tell you when to shock. It is the machine which is telling you. And defibrillator is manual defibrillator, which will you will have to see whether it is shockable or not and give. Details of the AED will be spoken to you by the next. So you check the defibrillator. So what you have to do is you have to put the 2 pads, and you know it is anterior posterior. One is below the clavicle on the right side, below the clavicle, the right side of the sternum. On the right side, you are keeping 1 pad. The other, and that is in the mid clavicular line, and the other one is next to the apex, below the apex beat. That is the mid axillary line on the left side. So this is where you put it, and this is called anterior posterior positioning. So while attaching the pad, do not stop chest compression, because you should know that if you stop chest compression, there is no coronary perfusion pressure, there is no cardiac output. So absolutely, there is no coronary pressure. You will have to continue your compression. But when you are analyzing the rhythm, do not touch the patient, because it will give a bias thing. When you are resuscitating, it will think, the AED will think it is a normal rhythm, and it will tell you not to shock. So when you are using AED, it will tell you whether it's shockable or non-shockable. If you are using a defibrillator, you will see the rhythm, and you all know that fibrillation is the rhythm, and pulseless ventricular tachycardia is the rhythm which needs a shock, and you have to give the shock. So you should know that there are two defibrillators. One is biphasic and the other one is monophasic. Biphasic, the current flows in two directions, and monophasic, the current goes in one direction. So since the current flows in two directions in a biphasic, what the current needed will be lesser to suppress an arrhythmia, where in monophasic, it is more because the current flows in only one direction. So the charge joules required in a monophasic, it will be more, that is 360. And in a biphasic, it will be 120 to 200 joules. And if it is AED, it is auto-select. So once you find that, you do the shock, immediately you should start the chest compression, resume chest compression. Because what you have to understand is, even though like most of the people, what they do is they look at the monitor whether it has come or not. No, but even if a pulse has come, that is not sufficient for an effective cardiac output. So that is why they say that you resume CPR for another 2 minutes, and you continue this 5 cycles of compressions and 2 breaths. So if after that, if victim starts to breathe normally, place in the recovery position. So that is a recovery position which all of you know of. You monitor the patient recovery position, see if he check the pulse, see he is okay. If he is okay, send him to the hospital. Now, this is a video just to demonstrate this thing.
Single Rescuer Cpr. If you are alone, ensure the scene is safe. And check response by tapping on both shoulders from front and asking loudly, "Hello, are you all right?" If there is no response, call for help and send somebody to get an AED or ask for it through mobile. Then check for breathing while palpating carotid pulse. It should take 5 seconds, but not more than 10 seconds. If there is no carotid pulse and normal breathing, start cycles of 30 chest compressions and 2 breaths. Compress at the center of chest, at least 5 centimeters, but not more than 6 centimeters, at a rate of 120 per minute, and allow complete recoil between compressions, without lifting head and without leaning onto the chest. Count loudly, 1, 2, 3 up to 30.
After 30 chest compressions, 2 breaths with or without a barrier device, or using a pocket mask, 1 inhalation for 1 second. 1 second for exhalation and then the next inhalation. Visible chest rise will be adequate. After second breath, 30 chest compressions are continued. After 5 cycles of 30 compression and 2 breathing, again look for carotid pulse for 5 to 10 seconds. And if no pulse, the cycles are repeated. If there are 2 persons, one can give chest compressions and the other person can give artificial breathing with bag and mask. After 5 cycles, persons are interchanged.
So the details of the 2 Rescuer CPR and the AED will be spoken to your next speaker. The whole credit of this video is
mute on. All you are muted. Not voice. Paul is the HOD of anesthesia in
of doing this. So we'll go to the next speaker. I will stop sharing.
Paul is the HOD of anesthesia Amala Hospital, and he is the secretary of ELS, Emergency Life Support, for once it was formed. He is also a member of Resuscitation Committee, IMA Resuscitation Committee, Standing Committee on Resuscitation. Oh. Oh, Vinil.
Thank you, sir. And
now Vinil is here. Vinil is from Jubilee Mission Hospital. He was the secretary of ISA Kerala State. Now he's the cardiothoracic anesthesia in Jubilee Hospital. Welcome to you, Vinil.
I express my sincere thanks to my Kerala State Branch and ELS Chairman Dr. P. Shashidaran for giving me the opportunity to speak on AED and to Rescuer Cpr. So before I start, I request Shashi sir or Dr. Paul to play the video of AED. That will be better, and after that I will start. So we will start with a small video. We will watch the movie, then we will move on to classes.
Can you see?
Sir, it's coming.
For CPR.
Sorry.
After a few cycles, the person.
Started screen sharing. Any technical issues, sir?
No. Okay.
After a few cycles, the person giving chest.
Sir, you have to
Rescuer Cpr.
stop sharing and do it again because it is not coming.
And it's not visible. The screen is not visible. Dr. Paul, you can share if it is ready with you.
Sure, yeah.
Any one of you?
Okay.
Yeah.
Yeah, now it's
ready. After cycles, the person giving chest compressions will be tired, and the compressions may be less effective. CPR may be provided more effectively if more trained persons are available. Now we can see how CPR can be done more effectively with 2 persons.
If there are 2 persons, there will be less interruptions in compression, more effective breathing, and more chest compression fraction. CPR may be continued for longer time with less exhaustion.
First person assess the scene safety, check response, call for help and start CPR. Second person reaches with an AED and bag and mask. Second person attaches the AED pads. Further respirations are with bag and mask.
Once the AED is switched on, further CPR is done as per AED prompt.
Shock advised.
When shock is needed, second person should press the blinking button. Continue CPR. Second person starts 30 chest compressions counting 1, 2, 3 up to 30. First person then moves to the head end and gives 2 breaths. 1001 first breath. 1002 exhalations. 1003 second breath. Compressions must be started immediately after second breath. 1, 2, 3, 4, and so on.
After each 5 cycles of 30:2 CPR, AED analyzes the rhythm. At this time roles must be changed. Once the AED prompts no shock needed, continue CPR. After 5 cycles of 30:2 compressions and artificial breaths, carotid pulse is checked. If there is no pulse, cycle is repeated. If there is pulse, watch for respiration. Artificial breathing is given at the rate of 1 breath every 5 seconds. 1001, 1002, 1003, 1004. If there is pulse and normal respiration but no response, the victim may be turned to lateral position. This can be done even if there is only one rescuer. Place the arm near to you at right angles. The other arm is placed to the opposite cheek. The farthest knee is bent and the body is turned to your side. Head is turned backwards. The advantage of this position is that there is less chance for aspiration and airway obstruction. The victim must be observed in this position till expert team arrives. Never do this if spine fracture is suspected.
Thank you, sir, for this video. This was the 2-person CPR video. And request to play the another video, one more video we got that is that shows the use of AED. So if it is there, that will be better for us to understand the, how to use AED. Is it available? Otherwise, we'll start with the class.
Yes, you can start. You can start the class, lecture. You can start the presentation.
Yeah, okay. Hope my screen is visible.
No. Ah, yes, now it is okay.
Not visible.
Yes, it is visible.
Yeah, thank you,
You
sir.
are audible.
So, you have already learned about this the first step of CPR, which and how to handle the resuscitation. Now you all know, you have already learned how to assess, how to make sure that the scene is safe, how to assess the patient, whether the response is there. So how to assess the response, whether the pulse, first to assess the response, then the pulse is there or not, or check the breathing. And after that, how to call for help and how to activate the emergency response system and to request for AED or defibrillator. And after assessing, you have started your high quality CPR or chest compressions. Shashi sir excellently explained in a very good manner in Malayalam how to start the chest compression, how to perform the chest compressions, and how to perform the COLS for the lay persons. So in a cardiac arrest scenario, we start with chest compressions. Then we add. Then you have attended the class of Dr. Brajesh, who added breathing. So we started with chest compression, then we added breathing to it. Then after that, Dr. Paul explained very well in a very well manner how to coordinate this chest compression and breathing. So now we have added. Now we are planning to add one more thing that is called defibrillator or AED. So the resuscitation, we start with chest compressions, and we started with 30 chest compressions for in each set. Then we added 2 breaths, so 30 chest compressions and 2 breaths in one cycle, and we continued it for 5 cycles or 2 minutes, and then if AED is available, what our plan is to use the AED. Now we will see how to use our AED. Sorry. So after assessing the patient, we will get you can appreciate the 3 columns which in green color in our table. So after while analyzing, you will be getting either the patient with a normal breathing with a definite carotid pulse, or abnormal or no breathing with definite carotid pulse, or abnormal or no breathing without definite carotid pulse. So if the patient is having normal breathing and definite carotid pulse, as Dr. Paul told, you have to observe the patient and keep the patient on you have to observe the patient for and you have to reassess the patient every 2 minutes and keep the patient on recovery position, and you have to shift the patient to the nearest hospital. If the patient is having abnormal or no breathing and with a definite carotid pulse, you should give 1 breath every 5 seconds, and you have to reassess the patients in every 2 minutes, and you have to check the pulse in every 2 minutes. Then come to our part, that is the major part, that is no breath and no carotid pulse. So here we have to start high quality CPR as the earliest. You should start with 30 chest compressions and 2 breaths, and you should continue these cycles till the AED arrives. So why AED or defibrillator we are emphasizing? What is the importance of defibrillation? So the probability of successful defibrillation diminishes with time. The survival from witnessed with cardiac arrest decreases with 7 to 10% per minute if there is no CPR is performed. This survival from witness cardiac arrest patient reduces 3 to 4 per minute if bystander CPR is performed. So you can appreciate the difference between 10 minutes per minute and 4% per minute. So if bystander is performed, at least if bystander is performed a CPR, like COLS is performed, the survival rate is diminished only 4% per minute. So at the same time, the importance of defibrillation is come here. If you appreciate the last line of the slide, 90% patients with primary ventricular fibrillation revert to normal rhythm with defibrillation if done within 1 minute. So if you perform defibrillation within 1 minute, 90% of the primary ventricular fibrillation revert to normal rhythm. So that is the importance of defibrillation in cardiac arrest. And most common causes of cardiac arrest in adult patients are ventricular fibrillation. So again, we come to the table. So you are performing your chest compression and 2 breath cycles you are going on, it's continuing. And once the AED comes, what you should do? That is the important. You should attach the, so before attaching, you should switch on the AED. So if you are getting an AED, it will be easy for you to perform the resuscitation because AED got its prompts. AED prompts to you what you have to do. It will advise what all steps you should follow. So you have to just follow the prompts of the AED. Once you switch on the AED prompts will come that you attach the pads. So AED got 2 pads. So one pad you have to attach on the right infraclavicular region, and the second pad you can attach on the left inframammary region. So as shown in the picture, you can attach 2 pads and you can connect the cord to the external defibrillator. Then as soon as it connects, most of the AEDs, they got automatic analyzing system. So they start, the AEDs start analyzing the rhythm. So some of the AEDs, if the automated system is not there, they may have a separate switch for analyzing. There you have to press the switch. So while analyzing the rhythm, so you should not touch the patient. At the same time, while attaching the pads, you should not stop the chest compression. So when you are performing a chest compression, you before starting the chest compression, you might have activated the emergency response system. If 2 persons are there, you might have asked the second person to bring the AED and the other emergency equipments. So when the second person is coming, he should attach the pads without interrupting the chest compressions. That is very, very important. You should not interrupt the chest compressions. And once you have attached the pads, and then once you have connected the pads to the AED and it was switched on, then when it starts analyzing, you should not touch the patient. You should stop the chest compression while analyzing the rhythm. Otherwise, it will not analyze properly. So after analyzing, you get the result. Either the rhythm is shockable or non-shockable. If the rhythm is shockable, if you are using an AED, it will automatically announce that the rhythm in the defibrillator, you have to do it manually, or if your defibrillator got an AED mode, you can turn it on to AED mode and it will do it by itself. But at the same time, if you are using the defibrillator mode, you have to assess the rhythm by seeing the rhythm strip. You have to analyze the ECG, and depends upon the ECG, you have to do the shock manually. If you are using AED, it will do it automatically. automatically. It will, at least it will analyze and it will diagnose it automatically, and it will announce that it's rhythm shockable. If the rhythm is shockable, it will announce that it is charging. And while AED is charging, you will be able to resume CPR for the while, because you don't have to lose that time. So the chest compression fraction is very important. You can continue your chest compression while AED starts, and once AED starts, then the AED got a button, yellow button, or a brown orange button, it will start blinking. Blinking, that means the AED to shock, and shock, sure that in the patient while you are shocked, you should make sure that you are sure that are clear from you should show for deliver. So delivering shock
it is not clear.
AED will announce that. Hello.
I'm not clear.
Yes, sir. I'm not audible.
Yes, not clear.
So audible or not audible?
Audible.
Okay. Video is not clear. I mean, the screen is not clear.
Sound is not clear.
Now it's clear.
Yes, but video not. Sound is clear.
Let me see. Okay. Sound is clear. So yes. 1 second.
Now,
so
there is. Yes. Now it is okay.
Now it's okay, and sound is also clear. Okay.
Yes. Yes, sir.
So if it is non-shockable rhythm, the AED will announce that its shock is not advised, and at that time you should continue your chest compressions. So now we will see in detail how to use the AED. I already explained it. I think Dr. Paul also explained in a quick manner. So I'll just repeat it because these are the key points for use. The search will not be remembering all the things. We have to remember the thing, repeating 3 times or many more times. So this is the picture of the AED. So once you receive the AED, you have to turn on it. Then once you turn on, and you have to expose the chest of the victim, and you should attach the pads to the bare chest. At this point, I would like to mention that if the chest is wet, you have to clean that patient. It should not be, the chest should not be wet. So you have to clean with the cotton or some cloth, you have to clean the patient, and you should make sure that the skin is dry, and then you have to attach the pads. And if the patient is a hairy patient, if you got 2 pads, you can do one trick. So you can use your you can attach your first pads, and if you quickly remove the pads, the hair will be removed with that pads, and you can attach the second pads to shock the patient. So these are the tricks you can use. The steps you should use if the patient is wet or if the patient is a hairy patient. So first you expose the chest, then you should
sound is not clear. Sound is not clear. Sound is not clear. Picture is clear.
Once again, sir. Let me see the volume of my iPad.
Now it is clear. Okay.
Sorry for the inconvenience. What about this? What about now, sir?
Now it is okay.
Now it was okay. Okay.
Yes,
so after exposing the chest, you should attach the pads, and while attaching the pads, you should not interfere the chest compressions. And after that, while analyzing the rhythm, you should not touch the patient. You should stop the chest compressions and you should not touch the patient during analyzing the rhythm. And once analyzing is over, you can continue your chest compression while charging the AED. Once the AED is charged, it will blink the red or orange button of shock. While it is charged and ready to shock, you should loudly say that I am clear, everyone is clear. And you should make sure that no rescuer is touching the patient, and you should deliver the shock. So immediately after delivering the shock, you should resume CPR. So these are the steps you should continue. So every 2 minutes, the AED will analyze the rhythm and it will advise shock if needed. And while analyzing the rhythm, you can change your roles. So it's coming to the another point, that is switch the role of the rescuers if 2 persons are available. Because if 2 persons are there, and 1 person can continue CPR for a long time, chest compression for a long time, he will get tired, the compressor will get tired, and he will not be able to deliver effective chest compressions. So moving to the next point, that is, so continue chest compression till when you will stop our chest compression. So continue the chest compression till the victim is responsive. So how you can understand whether the victim is responsive? So if the victim is moving or coughing or vocalizing, you can understand that the victim is
voice is not
of the you can check the pulse. Check.
This is not clear.
Now it's audible, sir?
Yes, it is audible.
What about now, sir?
Yes, okay.
So continue the cycle of CPR of the victim till the victim become responsive. And if you can understand that if the victim is moving or coughing or vocalizing, so the victim is responsive. And if the victim is responsive, you should check the pulse and breathing of the victim. I hope I am audible.
Continue.
I hope I am audible. So I hope you understood how to use the
sound is not clear.
How to sir, once again, we'll do one thing. We have to, before going to the Rescuer Cpr, shall I log out and you can continue with our next session? So I'll just attach my mic with my iPad and then I'll join. So meantime, you will be able to continue with pediatric session. And after the session, I will rejoin with Rescuer Cpr. That will be better then, if it is not clear.
Hello.
Binil, have you got any problem? If there is any problem, Binil, Binil, you are muted. Binil, no sound. Don't forget or no.
Sir, Binil asked to go ahead with the pediatric resuscitation.
Yes, sir.
Next session.
You can start.
Binil അങ്ങനെ പറഞ്ഞു.
You can
അടുത്ത സെഷന് ശേഷം കണ്ടിന്യൂ ചെയ്യാന്ന് പറഞ്ഞു.
You ask Pushparaj to start. Dr. Pushparaj. Pushparaj, you start screen sharing. Sound on. Pushparajinoട് തുടങ്ങിക്കോളാൻ പറഞ്ഞോളൂ. അതെ, ഇവിടുന്ന് കേൾക്കുന്നില്ല, പറഞ്ഞോളൂ. അല്ല, പുഷ്പരാജാണ്, പുഷ്പരാജിന്റെ സ്റ്റാർട്ട് ചെയ്തോട്ടെ.
Dr. Pushparaj, you can start with the session.
Pushparaj, you can start. പറയാം. ബിനിലിനോട് ബിനിൽ അൺമ്യൂട്ട് ആക്കൂ. പുഷ്പരാജ് തുടങ്ങും. co-host അല്ല വിദേശിനോട് അൺമ്യൂട്ട് ആക്ക. ബിനിലിന് സ്ക്രീൻ ഷെയർ. പുഷ്പരാജ വേണ്ടത്, പുഷ്പരാജിന് ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ല.
Dr. Binil, you can start now. You can unmute and start. Dr. Binil.
Hello, can you hear me, sir?
Yes.
Can I start?
Yes.
Thank you, sir. My topic for today is resuscitation in child and pediatric victim.
Hello. സാറില്ലേ, പുഷ്പരാജ് തുടങ്ങിയിട്ടുണ്ട്.
More than thousands infants and children have cardiac arrest each year. Despite increase in survival and comparatively good rate of neurological outcome after pediatric inside hospital cardiac arrest, survival rates from pediatric outside hospital cardiac arrest remains poor, particularly in infants. The cause of cardiac arrest in infants and children differ from cardiac arrest in adult. Infants is less than 1 year, and the child is considered 1 to 8 years, and adults more than 8 years. Basic cardiac life support for children. Many similarities exist between the basic cardiac life support guidelines for adults and children. The main difference between the two are, for children, if two rescuers are available to do CPR, the compression to breath ratio is 15:2. If only one rescuer is available, the ratio is 30:2 for all age groups. For every small children, you can use one-handed chest compressions. The depth of compression may be different. For a child, compress the chest at least 1/3 the depth of the chest. This may be less than 2 inches for small children, but will be approximately 2 inches for large children. If you are the only person at the scene, and find an unresponsive child, perform CPR for 2 minutes before you call emergency medical service, medical system, or go look for an AED. In children, primary cardiac events are not common. Cardiac arrest is most commonly preceded by respiratory problems. Survival rates improve with early intervention for respiratory problems. Remember that prevention is the first link in the pediatric chain of survival. If you witness a cardiac arrest in a child, call emergency medical system and get an AED just as you would in the adult basic cardiac life sequences. One Rescuer BCLS for children. If you are alone with a pediatric victim, do the following. Shake and shout at the victim to determine if they are responsive. Assess if they are breathing. If the child does not respond and they are not breathing, yell for help. If someone responds, send the second person to activate the emergency response system and to get an AED. Feel for the child's carotid pulse or femoral pulse for no more than 10 seconds. If you cannot feel a pulse, begin CPR by doing 30 compressions followed by 2 breaths. If you can't feel a pulse, but the pulse rate is less than 60 beats per minute, you should begin CPR. This rate is too slow for a child. After doing CPR for about 2 minutes, usually about 5 cycles of 30 compressions and 2 breaths, and if other help has not arrived, leave the child to call emergency medical system and get an AED. Use and follow AED prompts when available while continuing CPR until emergent EMS arrives or patient condition normalizes. 2 Rescuer BCLS for children. If you are not alone with the child at the scene, shake and shout at the victim to determine if they are responsive. Assess if they are breathing. If the child does not respond and they are not breathing, send the second person to activate emergency response system and to get an AED. Feel for child's carotid pulse or femoral for not more than 10 seconds. If you cannot feel a pulse, begin CPR by doing 30 compressions followed by 2 breaths. If you can feel a pulse, but the rate is less than 60 beats per minute, begin CPR. When the second rescuer returns, begin doing CPR by performing 15 compressions by one rescuer and 12 breaths by the second rescuer. Use and follow AED prompts when available while continuing CPR until EMS arrives or patient condition normalizes. It's the pediatric BLS algorithm. Unresponsive without normal respiration, activate emergency response system, get AED defibrillator, assess pulse, definite pulse within 10 seconds, administer 1 breath every 3 seconds, add compression if pulse remains less than 60 minutes with poor perfusion despite adequate oxygenation and ventilation, assess pulse every 2 minutes. If there is no pulse and if it's on rescuer, begin cycle of 30 compressions and 2 breaths. If it's 2 rescuer, begin cycles of 15 compressions and 2 breaths. Then AED defibrillation is arrives, assess for shockable rhythm. If it's shockable, administer 1 shock and resume CPR immediately for 2 minutes. If it's unshockable, resume CPR immediately for 2 minutes. Assess rhythm every 2 minutes. Continue until ALS providers arrive or victim shows signs of return of circulation. Difference in infant and children. The response is tap on heel of infant. Pulse, infant is brachial pulse and child carotid or femoral. If you witness unwitnessed arrest, if you are alone, give 2 minutes CPR and leave for AED. Chest compression depth is 1/3 diameter of chest or about 5 centimeter in child, about 4 centimeter in infants. Compression ventilation in 2 persons is 15:2. That is 15 compression and 2 breaths. Artificial respiration is mouth to mouth and nose in infants. Hand placement for 1 person CPR is 2 or 1 hand on lower half of sternum in child, 2 fingers in middle of chest in infant. 2 person CPR, 2 thumb encircling hand for infants. Child pads for child, anterior posterior pad position. Defibrillator is preferred for infants. This brachial pulse feeling. BLS for infants. And coming to child ventilation, if masks are available, they should be used as in adults. However, you must ensure the mask is the correct size for the child. The mask should cover the child's mouth and nose without covering the eyes or chin. You will not be able to get a good seal with a mask that is too big. As with an adult, use the hand tilt chin lift maneuver to open the child's airway. Each breath should last 1 second and should cause the child's chest to rise. As with an adult victim, avoid giving breaths too quickly, as this may result in distension of the stomach, vomiting, and possible aspiration of stomach contents. The proper position means in the absence of neck injury, tilt the forehead back and lift the chin. For tight seal, use the EC clamp, which is the letter E and C formed by the fingers and thumb over the mask. And when ventilation, squeeze the bag over 1 second until the chest rises. Do not over ventilate. 2 thumb encircling hand technique. Automated external defibrillator for infants and children. An AED can be used on infants and children and should be used as early as possible for the best chance of improving survival. Check the AED when it arrives on the scene. Pediatric pads should be used if the victim is less than 8-year-old. Standard or adult pads may be used if pediatric pads are not available. If using standard or adult pads, do not let the pads touch. For infants less than a year-old, a manual defibrillator should be used if available. If a manual defibrillator is not available, an AED may be used. Some AED have a switch that can be set to deliver a pediatric shock. If available, turn the switch on when using on children less than 8 years old. If the AED cannot deliver a pediatric shock, an adult shock should be given. It is important to remember an electric shock may be the cure for a fatal heart rhythm. AED step for a children. First, you retrieve the AED, open the case, turn on the AED, expose the victim's chest. If chest is wet, dry chest, remove the medication patches, open the pediatric AED pads, peel off backing, check for pacemaker or defibrillator, apply the pads. Upper is the right chest above breast and lower is left chest below armpit. Ensure wires are attached to AED box. Move away from the victim. Stop CPR. Instruct others not to touch victim. AED analyzes the rhythm. Message check electrodes. Ensure electrodes make a good contact. Make message shock, give shock. Resume CPR for 2 minutes and repeat cycle. The cause of cardiac arrest in infants and children differ from cardiac arrest in adults, and a growing body of pediatric specific evidence supports these recommendations. Thank you.
Thank you, Pushparaj. Pushparaj is a consultant anesthesiologist in Government Hospital, Talasheri. He is a co-convener of North Zone Emergency Life Support. Now, thank you, Pushparaj. Now I invite Koyakutti sir for the next presentation, Choki. Koyakutti sir, you may unmute yourself. Koykutti sir. Pushparaj, you stop screen sharing. Koykutti sir. Yes.
Yeah, start.
Yes, you can be seen.
I think the number has reduced to 350 now, and most of them are bored with the CPR. Now we will come to another topic, choking. As you all know, choking occurs while eating or playing by the children. Choking is a blockade of the upper airway by food or other objects. Am I audible?
Yes, very much audible.
Yes.
Choking is a blockage of the upper airway by food or other objects, which prevents a person from breathing effectively. Choking can cause a simple coughing fit, whereby it will remove the foreign body, but complete blockage of the air may lead to death of the person. It can be in three forms. A partial block, where the foreign body can be coughed out by the victim. So encourage the person to cough out. It can completely block it of the airway, then go for the first aid. Sometimes a complete blockade is okay, and the person may be unconscious. In that case, start with a CPR. Usually, when you see a choking person, first thing to do is ask them, are you choking? Because they may not be able to talk at that time. There may be difficulty in breathing or noisy breathing, squeaky sound when trying to breathe, cough weak or forceful, skin, nails and lips turning dusky or blue, or loss of consciousness. Especially the universal sign is holding the neck with both hands and waiting for the breath. The first and foremost is the Heimlich Maneuver developed by Dr. Henry Heimlich in 1974. This is nothing but an abdominal thrust. Stand behind the person who is choking, between the legs to stabilize the person. Just put one foot between the legs to stabilize the person. Place your arms around their waist and bend them forward little. Clench one fist and place it right above the belly button or the umbilicus. Put the other hand on top of your fist and pull sharply inwards and upwards as if going to lift the person. Repeat this movement up to 5 times. This is the abdominal thrust. When the person forward slightly and stand behind him, make a fist with one hand, apply the second hand over the fist, and make a quick and hard movement inward and upward as if you are going to lift up the person. This will usually dislodge the foreign body in the throat. Or if it does not occur, repeat the procedure. In a child, we may not be able to apply the pressure while standing. So just kneel behind the person and apply the fist and apply the pressure backward and upward. In infants, assume a sitting position. Just sit in, hold the infant face down on forearm, resting on your thigh. Support the infant head and neck with your hand. Keep face lower than the body. Thumb the infant gently in the middle of back 5 times. Then, this is the position. The child is put on the thigh with the head slightly lower than the body and the back is slapped from behind. If it is not coming out, turn the infant face up if not breathing. Using 2 fingers, give 5 chest compressions at middle of breastbone or middle of the manubrium. If not relieved, repeat the back blows and chest compressions to relieve the foreign body from the throat. This is the 2-finger compression of the chest at the middle of the manubrium, whereby it will dislodge the foreign body from the throat. In adults, the back blows are nowadays not advised as recommended by the American Heart Association. I will just try to play the video of animated video. With that, I will conclude. Let us see whether it is coming.
Yes. Enlarge it. Please enlarge it.
I'm trying.
Yes.
Aaron is eating a hot dog.
Doesn't matter.
No.
He starts choking. If you see someone choking, the first step is to determine how serious it is. Choking happens when someone is not able to breathe due to a fully or partially obstructed windpipe or throat. It will often happen when food gets lodged when swallowing. If you think someone is choking, ask them, "Are you choking?" If they can reply, it means their throat is only partially blocked. They should be able to clear it on their own by coughing. However, if they cannot reply, cry, cough, or breathe, then it means that their throat is fully blocked. They need your help. Have the person bend forwards and stand behind them. Use the heel of your hand, the area between the palm and the wrist, to hit them firmly between the shoulder blades up to 5 times. This creates a strong vibration which can dislodge the food. If they are still choking, give up to 5 abdominal thrusts. This is also known as the Heimlich Maneuver. Do not try the Heimlich Maneuver on a baby under 1 year old or pregnant woman, as it can be dangerous to them. Otherwise, stand behind the person, wrap your arms around their waist, and bend them forwards. Make a fist with one hand and place it right above their belly button. Put your other hand on top of your fist. Then, pull sharply inwards and upwards up to 5 times. If the person is still choking after doing 5 back blows and 5 abdominal thrusts, call 999 or your local emergency number. Continue doing 5 back blows and 5 abdominal thrusts until help arrives or until their throat has been cleared. To recap, if you think someone is choking, first ask, "Are you choking?" If they are, give up to 5 back blows and then 5 abdominal thrusts. If they are still choking, call 999 and continue alternating back blows and abdominal thrusts until help arrives. Now, Aaron cuts his hot dogs.
Thank you. Thank you, Shashiran sir.
Thank you, Koyakoti sir. Koyakoti sir is a senior most anesthetist in Kottayam district, and he was the member of mid-zone coordinator for even since the emergency life support was started. Thank you, Koyakoti sir. Now I invite Dr. Binil to continue. Binil?
Binil? Yes, sir.
Yes, you continue.
So my screen is so visible?
Yes.
Yes, yes. Just a moment.
So I'm happy to see more than 300 participants still at 9:55 p.m. So before winding up, we will quickly review or revise the today's points for as a take-home message. So just we will quickly see the two Rescuer Cpr. So we will start from the beginning itself, and we will quickly revise each point. So first, you should ensure the safe place if you encounter a cardiac arrest victim. So first, you should ensure that safe place. Once the place is safe, you should check response. Tap on the shoulder from the front and ask loudly whether he is all right or not. So you should check for the verbal response or purposeful movement. So once you check, you got two.
Have you got slide is not seen?
Slide is not visible?
No, only you are seen, not slide.
Oh my God. Okay. Technical glitches. I will share again. My God, it's not sharing.
Vinil?
Yeah.
Did you stop sharing and did again?
No, it's not coming. I don't know what happened.
There is no issue. We have one more day with that. You can
I think we will. It's just revising all the points which you have discussed today. I think next day, if you can allot around 5 to 10 minutes.
Yes, sure.
We will revise it. That will be better, I think.
Yes, okay.
Okay, Binil, thank you.
Sorry for the inconvenience caused because of me.
Delegates who are here even now at this thing at this time, and around 290 people are there. Next Thursday we will be coming again with the trauma part, first aid, and you have eminent speakers in that. Please don't miss the next session. And once again, we thank the whole people who have come over to attend this and giving us support. And the main idea, as I told you, it is to reach to every citizen. Every citizen should know what to do when something happens like that. So that is our motto, and we have training 25 lakhs. Yeah, definitely. But the ultimate aim is to reach to every person, and your two hands, as Dr. Chakra was saying, can save lives. That is what you have to bring, and it is possible with each one of you. Thank you very much, and thank you, the technical team of IMA. We had a few hitches, but next time we will see to that these things will not happen. And a big good night to you all.
Thank you all.
If somebody wants to ask something, definitely
any questions?
They can ask. Questions they can ask.
Unmute. And everybody unmuted.
Sir, one question.
Hello, sir.
Abdullah sir.
Responsive patient and non-responsive adult പക്ഷേ പൾസ് ഇല്ല, റെസ്പിറേഷൻ ഉണ്ട്. പൾസ് ഇല്ല, റെസ്പിറേഷൻ ഉണ്ട്. CPR കൊടുക്കണോ?
Hello, sir. Am I audible?
കേൾക്കാമോ?
Hello.
Hello.
Hello, am I audible?
Question.
Patient non-adult ആണ്, non-responsive ആണ്, pulse ഇല്ല, respiration ഉണ്ട്. What to do?
I think pulse is not there. We have to give CPR.
See, the thing is like the chances of that is not there at all. Actually, getting what you are saying is there is no pulse but respiration. That condition may be the agonal gasp. It may not be a respiration. It is very unlikely, and it won't be there like that.
Go for CPR.
Whether I have answered your question, I don't know.
So we have to go for CPR.
Yes.
Hello?
Go for chest compression.
Yeah, we have to go through chest compression. It is agonal gasp. It is not the normal one. Agonal gasp, as you all know, it will be only in 1 minute, 2 to 3 or 4, and it will be a deep breath, not like your respiration, which will be there for which will be there for 10 to 12 breath per minute. So agonal gasp, it is very easy to make out also, like it will be a deep breath and all your head, the jaws, everything will be moving on. So we have to discriminate between agonal gasp and the actual breathing.
Sir, am I audible, sir? Hello?
Yes, you are audible.
Sir,
Introduce yourself, please.
Sir, you have said that if you have 90% the survival is in ventricular fibrillation, if fibrillation is given within 1 minute. So in a hospital setting, whether we have to, if there is defibrillation available, we should give first defibrillation or CRP first. If the first we give defibrillation, will it be a better choice? Or is there any trial that defibrillation first and CRP first is any different, sir? Hello, sir.
If the defibrillator is ready, if the patient is in ICU, give defibrillation first. But till the defibrillator is ready, you can give chest compression and artificial respiration.
It is not easy. It is not easy to get the defibrillation immediately. It will take at least few seconds. That seconds you can do chest compression. That is what we are trying to say. But as early as possible, try to defibrillate the patient. It's not that easy to defibrillate within 1 second. So that is why we are telling to do chest compression. Definitely defibrillation is better. If it is the VF, definitely every minute it goes, the survival rate decreases 10%.
Sir,
yes.
Is there any role of adrenaline and vasopressin during resuscitation, sir?
That will come across in this comprehensive cardiopulmonary life support. We are not discussing it now. We will arrange comprehensive cardiopulmonary life support in another session.
Sir, since he has asked, I will tell you one thing. Vasopressin is no more in the algorithm. Vasopressin is not there at all.
And is there any role of hypothermia during this resuscitation?
Hypothermia. Yes, definitely. Hypothermia is there to those patients who has returned to spontaneous circulation and they are not following commands. That means there is some neurological issue what has happened, and definitely hypothermia. But in Indian standards, how can we give hypothermia? There are many things available outside, but now what we have here, what you can usually do is to give ice packs. That is the easiest way of doing it. What in abroad, what we have is there are vascular catheters through which the cold saline is passed through, so that the body will be to decrease the temperature. This is mainly to slow down the metabolism, and the injury will be which will be less. So only to those patients who doesn't follow the commands after return of spontaneous circulation. Hope I have answered your question.
Hello.
I am Abdurrahman from Thiru.
Yes.
If a person is already fitted with an ICD, is there any role in doing CPR?
What is IC?
Intracardiac device, including defibrillator and pacemaker. Already the person is having that fitted to his heart.
Paul?
See, already that patient is having, that may be the one reason, maybe that the device has stopped. There is some other issue with that patient. That doesn't mean that you should not do the CPR. You should definitely try to do. And why CPR? What are you going to achieve? You are pushing the blood to the brain and other structures. It is just a compression between the sternum and the vertebra. So definitely you should do.
Definitely we should do. Yes.
Sir, emergency numbers 108.
Do is later transvenous spacing. Transvenous spacing. Yeah. Any other questions?
One who is asking emergency number? Yes. Somebody.
108. 108 is the emergency number throughout, and there is also 112, which goes to the nearest mobile tower, and that goes to the nearest police station. Earlier, we had only 112.
Always.
Now you have universal, that is national 108.
Always better to call the nearest hospital.
188 is for ambulance by government. This free transportation. 112 is national level for all in emergency.
112 is the yes. All the number you must teach. Any other questions? If there are no more questions, Paul, please conclude.
I already actually I had spoken that we thought about the questions.
Yes.
Thank you very much, and thank you for the interaction. We should come again.
Thank you all. Didin, you can stop. Close.
Hello.
Didin.
Bibil was trying to call. I came. I just through the phone only I have taken. So I don't know why he's calling.
Didin, can close.
Okay. Thank you. Good night.
Good night to all. Thank you all. We can meet next Thursday.